All right, we're good now?
Yep, I'm ready to start.
Wonderful. Okay.
Hello, I'm Maddie Van Ouderen, the Executive Assistant at MCEP. I would like to introduce Dr. Margarita Pena, Dr. Matthew Wheatley, and Dr. Anwar Osborne as co-directors and moderators. Thank you all for joining us for our second day for our virtual MCEP Observation Medicine Science and Solutions. We would like to thank Vapotherm for sponsoring and supporting our virtual conference. Although we were disappointed to have to cancel in person, we are happy to be able to provide virtual CME. To claim CME, please make sure your name is visible. We will be able to see who is in attendance, and we will send an email in the next couple of days with instructions to claim your CME. If you are calling in and only a phone number is showing up, please just email us with your phone number and we will send you instructions. If you have any questions, please utilize the chat function, as the co-directors and I will be keeping track and asking the speakers your questions at the end of their lecture. Also, feel free to post in the chat to engage with other listeners. Please make sure that while the presenters are presenting to turn off your camera to avoid distractions. And without further delay, I want to introduce Dr. Margarita Pena to give a few words before we get started.
Oh, actually, just welcome everyone, and I'm actually going to turn it straight over to Matt.
All right, wonderful. Well, welcome back, everybody. Thank you for coming back for day 2 of our virtual conference here. So we're going to start right away with some discussions of established pathways and protocols for your OBS unit. So first up is Dr. Brian Heastand, who is a full professor of emergency medicine at Wake Forest Baptist Health, where he wears many hats, sometimes literally, sometimes figuratively. So take it away, Dr. Heastand.
All right, can you guys see my slides?
Yes, sir.
Very good. So thanks everyone. Glad to be part of the effort once again. This is absolutely the best observation medicine conference in the country, and to be a part of it every year is very gratifying. We're going to talk about syncope in observation, or DFO in the CDU. Done fell out for those of you who are not from the southern region. So no relevant disclosures. Our objectives, we're going to discuss observation management of syncope, who makes a good candidate, and what should you do with them once you actually have them. So first question with any protocol that you are looking to establish is, should you? You got to see if you have the patient volumes and the right phenotypes for what you're going to do. You got to make sure you have staff and physician buy-in. You need to make sure that you have the availability of diagnostic resources, especially on the weekends. That can be killer sometimes. And then make sure you've got consultant support versus, are they going to be a stonewall if they need to get involved down the road? One of the biggest keys on determining whether or not you've got the population to go after for a particular observation protocol is your PEPR report. The PEPR report is provided by CMS to your hospital. One of the many tabs on there is the one-day stay medical DRGs. So remember that one-day stays for inpatients are a prime target for observation management. This is a breakdown of our region here in North Carolina as to what are the typical one-day stay DRGs for inpatients. And you can see a lot of the typical things that make up a good observation unit. Matter of fact, we have a great observation unit. As a result, this is our particular breakout tab for our facility, and most of those diagnoses disappear. We don't have an issue with one-day inpatient stays because we run these through our observation unit, including syncope. So let's talk about the vapors. Let's talk about DFO. Just was out for a minute. And everybody's familiar with the definition. It was transient. They came back on their own. It's not epilepsy. It's not drugs. Spontaneous recovery is key. Lots of visits, lots of money, and there are a lot of different causes, because syncope is not so much a diagnosis as it is a final common pathway of cerebral hypoperfusion. So that makes it a little challenging to standardize the workup as well as the risk stratification. Again, based on NAMC's data, it's steady. We have a continuous flow of people who pass out and then come to the emergency department. Not in the first decade of the millennium, we really didn't move the needle too much in terms of the overall admission rate. I'm going to suggest that we have done better than that in the past 10 years, but I'm waiting for the data. So syncope is really easy sometimes for those that are no risk. Sometimes it's really, really easy for those that are high risk. If you got the sawtooth pattern, if they're redecorating the ED bay in scarlet, or the CT scan with worst headache of life is clear, well, great. We don't need risk stratification schemes for this. We don't need decision scores. And that's one of the problems with some of the early work that was done with Syncope, is it included the really, really easy high risk people in deriving the decision scores. But if it's not super easy on either direction, then we have obs. And we have science behind this. We know, thanks to a lot of work from Ben Sun and his cohort, we know that we've got randomized controlled data that lower resource utilization in obs, similar at safety profile at both 30 days and 9 months. So Ben's work excluded the low risk patients, excluded the high risk patients. So really took after the ones that we have a clinical question. Okay, great. I can't admit this person easily. What do I do with them? Well, putting them in obs is probably going to be a really good idea. We know that hospitalization is really, really bad for dementia patients, that it's low yield and it's high risk for iatrogenic adverse events. Falls are just the least of the issues, sundowning, and there's not a lot of benefit to bring somebody fully into the hospital in the elderly dementia population. And those are the ones that very frequently present with syncope because they were found on the floor, and the assumption is, well, they must have passed out. Inpatient has non-standardized workups, variable yield, high cost, and these costs are deferrable. And we've got simulations suggesting massive amounts of savings on a national scale by using observation care for syncope. So who can go home right now? Age less than 50, clear vasovagal cause, normal EKG, normal cardiac exam, no history of cardiac disease. We don't need to obs these people. These are folks that, outside of some of the very few high-risk features, such as exertional syncope while playing basketball, something like that, roaring cardiac murmur, but that'd be normal cardiac exam, these people can go home. There are conundrums if you look at the various specialty society decision rules and guidelines. Is there an age cutoff? What do you do? Heart failure is a risk marker, but are we talking acute heart failure or history of heart failure? Acute coronary syndrome events versus history of coronary artery disease. And what we've seen from some of the data that's been done out of Europe, one, there's no such thing as too old for obs. The elderly population does benefit from observation care just like the younger, and a history of cardiac disease does not automatically rule you in as high risk, thou shalt come into the hospital. And this data can be found from the work of Numeroso et al. One of the best, more validated scores out there is, as one might assume, coming from our Canadian neighbors, and the Canadian Syncope Risk Score. And what we see, it runs various clinical factors and gives you a scale from -3 to 11 with a estimated risk, and this has been prospectively validated. And what we can, couple of key factors here. One, they are getting troponins on every one of these patients. And in the era of high sensitivity troponins, how many are going to go over that 99th percentile versus in the indeterminate range versus over the true positive? I think we're still going to be finding our way forward with this. But overall, in general, these are valid these markers have face validity and can provide a guide as to who should go in, who is not high risk enough to need automatic admission. So again, validation outcomes. If you had very low to low risk, I like those zeros. No deaths, no ventricular arrhythmias, a little bit of atrial fib down the road showing up in follow-up, but overall not too bad. And even when you extend it out to a medium risk stratification score, you get some ventricular dysrhythmias and a little bit of death. Canadian folks were not bothered by this because they have fewer lawyers than we do, but it's still well within the less than 1% safety threshold. So what do you do with them once you put them up in the CDU? The first thought is to test everything you can test. That's our natural bias, but that's not particularly valid. That's not the best way to approach the management, because again, syncope is it's hard to do one diagnostic pathway to rule them all, because this is a clinical guess. This is an overall composite as opposed to a single diagnosis. So the trajectory that you're going to follow for your workup is very much determined by the initial H&P. Listen to the patient. Do they need IV hydration because they're dry as a stick? Do they need serial troponins because this is a potential ACS event that led to the syncope? Or do they need serial hemoglobins because there might be some GI bleed going on it? Cardiac monitoring is kind of a no-brainer for most of those because what we're worried about the most is cardiac syncope. Now, if the patient already has a device in place, get that device interrogated, because if they had a syncopal episode and you can check the rhythm monitoring while they had their syncope, then you can tell whether or not you're dealing with cardiac monitoring or not. I had a patient last weekend, had a loop recorder implanted from his last syncopal episode, but had a spontaneous loss of consciousness in the front seat of the car, passenger, not driver. We were able to interrogate the loop recorder, and there was absolutely nothing going on from a cardiac standpoint. This patient actually turned out, in all likelihood, to be having seizures instead of syncope. So we were able to change his trajectory from our cardiac colleagues over to our neuro colleagues in follow-up. If you don't have ready access to an interrogator, all the manufacturers have read-only interrogators where the data goes to the company, and they will provide a readout on that. This is really a must-have device for your patients with implanted cardiac devices. That being said, so cardiac echo, maybe. If the patient does not have a history of heart failure, doesn't have a history of coronary artery disease, normal EKG, normal troponin, normal B-type natriuretic peptide, if you were 0 for 5, you had no value whatsoever to the cardiac echo per Probst's work. And that, again, requiring troponin testing, requiring BNP testing, probably not indicated in every patient. But if they have a normal cardiac exam, if they have a normal EKG, the value of a cardiac echo is pretty low. So again, this was retrospective work. Validation is pending, but not every patient on syncope needs cardiac echo. Tilt table, not a fan. The diagnosis of neurocardiogenic syncope, positional orthostatic syncope, that's an important one for the patient's overall quality of life. It is not an emergent life-threatening cause that we need to rule out in the ED and by extension the observation unit. Disposition, unfortunately, syncope is not one of those meaty, satisfying, okay, I know what was wrong with you and therefore we've got surety. A lot of times it's, well, I know what's not wrong with you and it's time to go home. So depending on history, you may see benefit to having outpatient cardiac monitoring. You can use Holter, you can use Xiopatch, you can use implantable loop recorders. Going to the point of referring for implantable loop recorders is a little bit large step, and all these external monitor functions have higher yield if you've got if the patient presenting with palpitations, presenting with or EKG abnormalities. Tilt table may be appropriate as an outpatient, but that's a 100% primary care diagnosis. That is not something we need to establish from the observation unit. So in conclusion, obs management of syncope is feasible. It provides cost savings, bed savings, risk stratification is out there, is validated, and can be brought to an emergency department near you. Thank you very much. I know it's an abbreviation. We are trying to get everybody through in time, so I will say thank you, and I think we're doing questions at the end, Matt.
Yeah, I have one, just I guess as we're getting the next speaker up. How do you handle the providers that want, the platinum package on everybody that they put back there? We want the echo and the stress test and the serial troponins and the serial H&Hs. I mean, do you try to handle that on the front end? Do you do more kind of education, or are you just following your length of stays and just making sure by and large you're not having any kind of acuity or mission creep?
Right, that's exactly it. We monitor our admission rate, we monitor our length of stay. Adding in, so serial troponins and serial hemoglobins, kind of a mismatch, but it's not the worst thing in the world because they're already getting one serial blood draw. It's when we start looking at a stress echo and a 2D echo and Carotid Dopplers, which no, or head CT, unless they bonk their head on the way down, no. There are, so, and we will do individual follow-up and feedback. We have a very experienced cadre of nurse practitioners and PAs that help run our observation unit, and they are not shy about letting Dr. Stapira who or myself know about, hey, did you know what Dave did last time? So they're pretty good at providing opportunities for targeted feedback.
Wonderful. Okay. Well, let's go ahead and move on to our next speaker here. Dr. Stapira is coming also to us from Wake Forest Baptist Health, where he's assistant or associate professor of emergency medicine, and will be talking to us about heart failure. So, thank you so much.
I really appreciate the opportunity to be able to talk about heart failure today. Here are my disclosures, and the only one that's important is I am the current medical director for our CDU at Wake Forest. I wanted to give you a little bit of an idea of what the patient population at Wake Forest looks like in the heart failure observation protocol. We see 65-ish year-old patients with a pretty wide standard deviation, nearly equal male to female. Then the next bullet is interesting in that 64% have a documented weight gain of 10 pounds or less, leaving a significant portion of our patients with a weight gain of over 10 pounds. And I think that's an interesting fact. It's a part of our data and something that our providers, both CDU providers as well as our providers in the primary emergency department certainly key in on. 30% of our patients have preserved EF heart failure. 95% receive at least one dose of IV Lasix, with 60% receiving a second dose. It's very uncommon for our patients to have a creatinine over 2. And 25.5% of our patients do not receive any cardiology consultation. Moving on to outcomes, of all our patients that are on the CDU observation heart failure protocol, 46.1% are admitted. And of those patients that are admitted, 25% have a length of stay over 7 days. And of the patients that are admitted, 56, almost 57% return to the ED or are readmitted within 90 days. So this is a challenging disease process. This is a disease process that has continued increase in both incidence and prevalence. It's continues to be the most expensive CMS diagnosis, and it has a high mortality. And it's difficult for us to identify a perfect patient for heart failure observation. So the question is, does the perfect heart failure observation patient exist? And it's almost the search for the holy grail as far as I'm concerned. And I haven't identified it yet here at Wake Forest. I'm looking, I'm searching. And that's a unfortunate problem that I don't think is unique to us. It will cause providers to act in certain ways and go back to the previous idea of total amount of weight that they've gone up. And many patients are not brought into observation simply because of that. And that we have not found to be the magic pill that if you're 10 pounds or less, you're a better candidate or not. Of the patients that are discharged, 56% of them are female. and 32.7% of the patients that are successfully discharged within 24 hours did not receive a cardiology consult. Interesting information as far as I'm concerned. Those statistical significance hasn't been reached in our small data set. So I wanted to share a little case study to pick up on a very important part of heart failure. This is a case of a 67-year-old female with significant past medical history, of course inclusive of heart failure, and she presented with a 4-day history of swelling in her extremities, both upper and lower, as well as dyspnea on exertion. She had had it before. She stated that she continued to take her Lasix every day as prescribed, but she was 22 pounds over her dry weight. Her last ejection fraction was 45%, and she really felt tired and had a non-productive cough. As you can see, her blood pressure's up, but the rest of her vital signs look pretty good. Physical exam basically showed that she had the fluid both in her lungs as well as her extremities. Her labs are, the important ones are there. Pretty stable as far as her white count and her hemoglobin. Her BNP was above our upper limit, and her troponin was mildly elevated. Sodium looked good, potassium's low. Her BUN and creatinine are a little bit higher than what we normally have in the CDU, but was stable for her, and her MAG was a bit low. Chest X-ray showed cardiomegaly with edema, so not an unusual patient. But right now, I want you to really focus on the potassium and the magnesium, because those are the things that can really creep up on you. The patient was given 40 milligrams of IV Lasix, was given potassium and magnesium replacement, and placed in our CDU OBS overnight, and continued to get diuretics and magnesium and potassium replacement. And we're really at a crossroads right here, because you ask yourself, what are you going to get and what are you going to find in the morning? And we found a patient that was in no acute distress, doing relatively well. But had the potassium and magnesium replacement not occurred, we would have been in a world of hurt, I believe. The importance when developing a protocol for heart failure really needs to pick up on the subtle things, needs to hopefully create a hard stop that diuretics are not allowed to be given in a patient who has electrolyte abnormalities without addressing them concurrently or first. So some of the pearls that I want to share with you that I've learned is the importance of home meds. Obviously, IV diuresis is the key. Our hope is that we can get the fluid off of our patients, but we really need to make sure that we're dealing with the patient as a whole, and they need their home medications ordered. Initial weight and strict I's and O's are certainly important, but frequently missed. So I really stress the importance of educating your staff and your faculty, your residents to check on these things, to make sure that the nurses are following through with the order to get an initial weight, as well as I's and O's. Repleting potassium and magnesium is certainly important, but you need to also repeat the labs at least every 12 hours. 12 hours is what I like myself, but you need to know where you're at, because you're giving the patient a large diuretic dose, and you need to make sure that the patient isn't developing a worsening electrolyte abnormality. Another important part of the treatment of this patient was the blood pressure control, and likely the blood pressure combined with her fluid overload is what caused her troponin to be mildly elevated in the face of a chronic renal insufficiency. So it's important to also address a patient's blood pressure inside of this protocol and monitor it closely. This is not a protocol that lends well to the Ronco solution of set it and forget it. So make sure that this patient population is cared for continuously, even on the overnight shift. Certainly not a out of sight, out of mind patient population. As we said, the mortality of heart failures very high, and it's not something we want to put on the back burner. And then the last bullet point is identify opportunities for success in the real world. And what I mean by that are make sure the patient has access to medications, not only from the pharmacy, but able to get it in their mouth every day. Good food without sodium. They need to have transportation to appointments. And, the last two things are also very important in this population. It's important to assess their cognitive function because most of these patients do have some cognitive decline, some problems there, as well as depression. So make sure you're taking care of your patient, soup to nuts, and don't put them on the back burner. I appreciate your time and look forward to any questions you may have.
Can I ask a question?
Yeah.
Um,
I love that picture.
Thanks. It's an Atlanta thing. So let me ask you this. If your admit rate is like 41%, do you personally think that you, as a seasoned provider that looks at all the statistics, are better than that 41%?
Probably worse. I just to be honest, I love to treat our patients in the CDU, and I'll certainly push the inclusion and exclusion criteria myself to see how far we can go and challenge the protocol itself, and I can do it rather safely myself. So I don't feel as though I have probably better numbers because I would prefer to take a chance and keep the patient overnight in a CDU and see if I can get that patient out. And I don't know if I necessarily win.
Yeah, I know in our CDU at Emory, what Nat and I a lot of times teach folks is like the people that do well are the ones that have like very obvious reason to have an exacerbation, like lost the meds, and then come in with elevated blood pressure, and then improve rapidly in the ER. So like these BiPAP folks that lost their meds with the blood pressure of 180, that gives you a lot to work with. It's just very hard to like carve out like a reproducible chunk of those patients in our experience, which is kind of what you're saying.
Exactly.
I think there was a couple questions on the chat. Do you have any experience with a rapid diuresis protocol? IV Lasix as frequent as 2 hourly or with more frequent electrolyte monitoring? And then
I do not.
Another one about using kind of large doses or Lasix infusions and maybe send home in return for not necessarily the ED, but to clinic or something like that.
Certainly both interesting, but no, we don't have either of those as part of our approach for heart failure patients.
Okay. And are you using any kind of BiPAP or anything in the CDU?
No.
Okay.
And we do have, yeah, we do allow troponin elevations, but they need to be established troponin elevations that they've had before.
How do you handle, so with the troponin elevations, do they need, so let's say, their baseline is 0.06 and they're 0.1 today. Do they need to get a second one in the ED to make sure it's not rising, or do you normally handle that on the CDU side and admit them if it looks like they're trending up, or, and then do you guys have high sensitivity troponin, or are you still on?
We do have high sensitivity troponin, and we do look at it in a case-by-case approach as far as what the patient's presenting with and what may be causing the exacerbation.
Okay. Well, excellent. Thank you so much for your presentation. I think right now we're going to switch to our next presenter, which will be Dr. Mace, who is a professor of emergency medicine at the Cleveland Clinic. And she is also one of the founders of this specialty and somebody who, I owe a lot of debt of gratitude for all the education and, you know, papers she's written over the years. So we're excited to hear from her today.
Good morning. Can you hear me?
Yes.
And can you see my slides?
Not yet.
Okay, let's try and pull them up. Let's see here.
You may have, well,
I've got them on my screen.
you got
So,
to do the little share screen thing. At the
share
bottom.
screen. Yep, I'm looking for that. Share screen. Maddie, it's not coming up.
You can do the Alt S.
I tried that.
Nothing?
Alt S. Okay, let me go. Alt S.
Yep.
All right, did it? Now?
Nope, I don't see it yet.
All right, let me
Your
hit Alt
camera on,
S
sorry.
again. I'm sorry?
Turn on your camera.
Turn on my camera. I don't
Yeah,
know,
it's in the left corner where it says start video.
Start video. You know, I don't see anything on my screen. Start video. Let me get somebody to help. Do you want to go to the next one and come back to me? 'Cause
Sure, if Dr. Pena is ready.
Margarita, do you want to do that? Is she there? All right, sorry about that. Let me see what I can do.
Sharon, do you want to do what we did earlier and have you just exit out and get back in if that's easier for you?
Well, I think while we're navigating the little bit of technical difficulties.
Yep, I'm working on it now.
Very good.
Just hit the slideshow. I want to start it. No, I'm already up. I need slideshow. I need slideshow.
Yeah, so you need to turn on your video and then you need to share your screen.
Share the screen.
How do I turn on the video? This is on.
Oh, is this on Zoom?
Yeah, it's on Zoom.
Okay.
Yeah, well, I don't see Zoom on.
Make sure that you maximize the screen. Sometimes the share screen's off the view.
It's maximized. You know, our hospital doesn't support Zoom. And so we have problems with this, so I do apologize.
Sharon, put your pointer in the left lower corner.
All right, there we go. Here we go. It's coming.
Yeah, now you should be able to share your screen.
All
All right,
right,
turn on
hit
your
share
video.
screen. Got it.
Turn on your video first.
Start video. Hit start video.
Yep.
Hit start video. Start video.
And now you're on.
All right, yay. All right, so let's share screen. And then let's hit this one. Yep. You see it now?
You have to select the slides.
Got it? Working?
Yep.
All right, so
Yay.
can I,
Then you go to slideshow and play from beginning.
where's slideshow in it? All right, good morning. We are going to talk on pediatrics. Thank you so much. Pediatrics is 25% of all your ED visits. So it's something you probably shouldn't ignore. Whether you're a community hospital or academic children's center, it would do you well to do pediatrics, so I'm going to speak for it. If you have any idea the number of pediatric admissions to the hospital, this is nationally, both in the US and Canada, that could be taken care of on the OBS, you want to take a guess? It's 70 to 85% of all kids admitted to the hospital could be taken care of in OBS. Okay, so with that, I'm going to say that my only disclaimer is that I'm author and editor of a textbook that most of the people on the panel today and yesterday have written for or will be writing in the next edition of the textbook. So thank you to them. I also want to thank Michigan ASIP and Dr. Pena for putting on the best conference on observation medicine year after year. So I'm going to put a plug for pediatric observation, and the optimal observation unit patient is really the easiest one to take care of. Now, in the last lecture, we talked about heart failure, which is probably the most difficult. So now we're going to talk about the patients that use the least resources. You do almost no testing. When's the last time you did an MRI on a kid? or a stress test, use the fewest medications, and almost never get a consult. We have the highest patient family satisfaction from the kids and their families, the fewest complaints, the best press gainies. I'm going to say that in theory, since there's few costs and few expenses taking care of these kids, you may have a higher profit. We have the shortest length of stay, the highest discharge rates from the OU, and we avoid a transfer. And if you're in a community hospital, you know it's a burden for the family to go to the children's hospital or academic center miles away, as well as the time and resources for you and your community hospital to take that time to send them there. And the PR of why you can't take care of me here. And in the academic centers, it makes more beds on the pediatric floor so that you're not wasting time, waiting hours in the ED to get a bed for your pediatric patients. So again, my plug is pediatric observation. You can do it anywhere in any setting. And if you are doing it, you're probably not doing it enough, and that 70 to 85% of kids who are admitted to the hospital could be taken care of in OBS. Okay, so what patient is the best candidate in my mind for OBS? It's the kids, because they're easiest to take care of. And the youngest age patients, many places in the children's hospital have taken care of neonates, patients with hyperbilirubinemia, for example. So as with adults, the length of stay comparing inpatient OBS with ED OBS is much shorter for the ED OBS. Okay, so I'm going to give you some general order sets, and you know they're pretty much the same as adults. You may have a few things. You may do a height and weight, but that's optional, and we don't even do that on most of our patients. I put in isolation, and I say that's per protocol because nurses know what it is. And often the number one and number two reasons for going to OBS in kids are asthma, respiratory, bronchiolitis, croup, pneumonia, and then infections such as dehydration with gastroenteritis or cellulitis. So you may want to think about that, but I always say per protocol because then I only have to look up what's contact with droplet precaution. And then wound checks, we put a lot of cellulitis in there, neural checks, seizures, and things like that. So very simple, very straightforward. Okay, vital signs, same as in adults, as often as you want it. Pulse oximetry, because most things in kids are respiratory. So you want to think about it. Orthostatic blood pressures, yes, we do monitor the kids sometimes, but most of the times you could just get away with a pulse ox or even no cardiorespiratory monitor if you have like a simple dehydration. Eyes and nose, yes, most of the time you won't need that. And other simple things, elevate the head of bed. If there's cellulitis of the hand or extremity, you may want to elevate that part of the body. So again, weight-bearing status, if they're a kid who's got a problem with an infected foot or something. Seizure precautions, that's another common thing for the observation unit for the children. Any special precautions if you need it. And diet, I usually just say age appropriate. And if they have formula, I check that. And you know, the parents know what the kids are on. So you just got to order whatever, Enfamil, Similac with iron. And activity ad lib, whatever's age appropriate, and if they need supervision. All right, there are probably only 3 medications that you could use to take care of kids in any observation unit, in general, okay? Tylenol, Motrin, and Zofran. And if you got those down, you probably could take care of most kids in your observation unit. Antibiotics would be the other category, and we'll go into asthma. And I give here the usual dose, which we all know, 10 to 15 milligrams. We usually go with 15. I put in the maximums that you give up to 4 grams a day or less, or 75. Motrin, we all know about that as well. But the thing here, put in the maximums. When you have a maximum single dose in kids, usually 400 milligrams or 40 mg per kg per day, up to 1.2 grams. And Zofran, again, our usual dose is 0.15 mg per kg. And I list these here. The max usually is the 4 milligram dose. So these 3 drugs would probably do most of your observation unit patients. All right. So our general order set, you can give boluses. In IV fluid maintenance, we actually have an app or a calculator in the order set where you just put in the weight and it gives you the maintenance fluids per hour. And the max again here is important, 125 milliliters per hour. And check whatever solution you want. These are some of the common ones. And if you want to add potassium, you can, the usual. Usually don't go with 40 milliequivalents per kcal per bag. That's a lot. We usually just stay with 10 or 20. And labs are probably mostly maybe a CBC, maybe a basic metabolic panel, chest x-ray or extremity film, but that's it. You're not doing MRIs. You're not doing usually CT scans, and you're usually not doing a lot of consults. Okay. Now, the one thing that you do want to put in there is probably some pediatric vital signs, and these are kind of things that will clue you in if the child is getting worse. I will say that in the 27 years we've had our odds unit and put pediatrics as well as adult patients there, we never really had problems with kids, but you want to have this in there as a safety feature. So heart rate low, heart rate high, respiratory rate, blood pressures, and we do it by infant, toddler, and child, just easier. And look at pulse ox, less than 95 for infants, and everybody else it's less than 93%. And then actually you're almost getting to the adult numbers when you get to the child range. Okay, adolescents probably almost consider them like adults. You probably could get away with using the same adult numbers, but these are what we use in our CDU. And for anybody, and all age patients, we want to know if they're febrile or if they're really low temperature and hypothermic. And the rule of thumb for pediatric urine output is 1 cc per kilogram per hour. Okay. So what's the most common things we put in? And so I wanted to give you the general CDU order sets. And now I'm going to give you the specifics for asthma, because that's probably the most common thing people put in the CDU. For kids, okay? The usual albuterol dosage, 2.5 to 5. And I'd say most of the time we just go with 2.5 or 5. And if they're infants, we just hit the 2.5. Continuous you can do. Again, I put in the usual doses. You can give the albuterol inhalers. You can even give Atrovent inhalers. And those are the same, 1 to 2 puffs every 4 to 6 hours. Prednisolone, prednisone, or methylprednisolone, most of the time you don't need IVs for kids with asthma. You can get away with oral medications, and so that's probably preferred. Would recommend prednisolone because it's a better taste. You could also give dexamethasone, PO. But remember, if you need to have an IV, methylprednisolone is the one you give either orally, IM, or IV. And sometimes in CDU, we do give MAG, and that dosage is 50 mg per kg. And of course, as with adults, the max is 2 grams usually. Now, you can do pediatric risk assessment just like you do heart scores with adult chest pain. That's optional. We have not used it at our place, but some people do. For pediatric asthma, there's all sorts of scores out there. I think if there's multiple scores for one disease, in this case asthma, it means that we haven't decided on which one is the best. So here's several in the PRAM, the PIS, and RADA. So with mild or moderate asthma, consider CDU. Severe, obviously, we go to the inpatient floor or ICU. For pediatric croup, most people use the Wesley Croup score, and I'll give you an algorithm that we use, okay? So this is a busy slide, but if you go over to the right-hand side of my right-hand side of the screen, respiratory failure would go to the ICU, obviously, with the usual treatment of episteroids and so on. If they're mild, hit them with the PO steroids and send them home. You don't need to do much more. But if they're moderate and maybe severe, the lower end of the 8 to 11 severe on the Wesley Croup score, always decrease the patient's anxiety and discomfort, have the patient hold them and comfort them. That's number one. Humidified air or oxygen, steroids, and then epinephrine. That's our mainstay for croup. And observe them several hours after giving them medications. If they're severe and they get better, you can improve, and they improve. Observation, give them antipyretics to treat their fever. Make sure they're taking PO. If not, you can start an IV and do that. If they're better and they meet your discharge criteria, you can send them home. If not, if they don't meet discharge criteria, then keep them in obs more and continue your current treatment. And of course, if they decompensate or get worse, hit them with an epinephrine and send them to the PICU. Okay? So I'll say that I know it was mentioned yesterday, somebody had a unit since 2009. Well, if you double that and add 6, that's the number of years we've had our OBS unit since 1994. Never had a problem with putting kids in the OBS, and we do kids and adults in our combined unit. My conflict of interest, as mentioned, is Cambridge publication, the textbook. Protocols and drug order sets and medications for pediatrics. We have one chapter done with myself and a pharmacist that gives you every medication dose for pediatric patients that you would ever want to use for your observation unit. And I'm happy to take questions, and I apologize for my technical difficulties. So think about kids. They're great to put in an observation unit. They take little resources. They're much easier to take care of than the adults. And they're also fun to take care of. So thank you very much. And I'll take questions either now or at the end.
Thank you so much, Dr. Mace. I had one question, if I could. Coming from a mostly adult hospital with a peds hospital across the street, I know that there's always a heightened sense of urgency when a parent brings a child in, kind of by accident and checks them into the ED. Have you run into any problems from either a hospital regulation or nursing standpoint in trying to create these and saying, oh, well, we only see kids over this age, or, what kind of nursing competencies do you need to get, not even like neonates, but, younger adolescents or, pre-adolescents, into an OBS unit?
Great question. Let me use an example of one of the community hospitals that one of my ex-residents went to a small town in a community hospital in a rural area in Ohio and started an observation unit. They took down to the age of 5. And I'll say, if you're in a community hospital, I really think it's a great thing, because sending it to me at the academic center miles away is a real burden for the family and the patients, getting transportation back and forth as well as other reasons. And when you send them, by the time you send them, they may be better. And then you kind of look like an idiot. Why did they send me? And then the Children's Hospital sends them home. So in that situation, definitely. Now for your academic center, one of the reasons that we did it at the clinic was because we never had pediatric beds. And I'm sure that's true at your Children's Hospital. For our simple gastroenteritis and asthma and those types of garden variety pediatric patients, that the beds in the Children's Hospital are taken up with the heart transplants and the autoimmune disorders and everything else that are there. So we would have pediatric patients in our ED for hours. So if you're thinking about that, one, there is no specific regulation against transferring if you're going from your place to the Children's Hospital or any other place, assuming they're stable and meet that requirement. For nursing requirements, when we started taking peds, we did have some pediatric in-serving of the nurses. They all had to have pails. They all had to have, we had them go up and work on the peds floor for a specific time before they came back and worked in the observation unit. We initially took down to a certain age. Now we started at like 6 months or a year, and then worked down to 2 months as our youngest age group. We still don't take neonates, although some places do, like hyperbilirubinemia at the Children's Hospital. Another one in Texas, and I'll credit them for doing new neonates. But most places, I would say, at least take teenagers. They're easy. They're almost adults. At least take down to maybe age 5 or 6, like my community hospital, because they're pretty easy to take care of. I think it's more difficult when you go younger. So, all right, don't take neonates, don't take 1-year-olds, don't take toddlers, but go with maybe age 5 or 6 and up. And I think you can do it. And if they can do it in the community hospital in a small town in Ohio, I think you can do it anyway.
Excellent. Thank you so much. I think there are a couple more questions in the chat, but I think in the interest of time, we've got to move on to Dr. Pena's presentation. So Dr. Pena, who we've all met as one of the course co-directors, is the medical director of the Clinical Decision Unit and Associate Program Director of Emergency Medicine at Ascension St. John Hospital and Medical Center in Detroit. So we're very happy to have her here today to talk to us.
All right, sorry, folks. I forgot to unmute this. Let me just screen share real quickly. Can you hear me?
Yep.
Okay, great. All right, here we go. All right. All right. We're good? Matt?
Yes, sorry, I had to unmute myself.
Oh, that's okay. That's okay. All right.
We can see
So,
everything.
yes, I'm going to be talking about COPD and kind of what's new in protocols and pathways, and kind of fortuitous because just coming up on November 18th is World COPD Day, so I thought that was pretty neat. I'm going to start with our own CDU protocol and pathway. We have a CDU that's a 28-bed ED observation unit, and in fiscal year 2020, our COPD/asthma, because we do the data with a combined data set. It was the third most common condition in our CDU, and we saw a total of 448 patients in fiscal year 2020, and it represented 7.4% of our volume. This is the protocol that we use, and I'm going to highlight just some specific areas in each of them. So if we start off with our inclusion-exclusion criteria, we do have the inclusion criteria that if patients have some improvement after initial ED treatment of no more than a total of 15 milligrams of albuterol and 1.5 milligrams of Atrovent, which is kind of the hour-long treatment, and they show improvement with this, they would be good candidates. We do stress the importance of using an ambulatory pulse ox if the patient's capable of doing this, because we find that it does sometimes change disposition or consideration of another comorbid condition if the patient significantly desaturates. We use 90% as our cutoff for two reasons. The first is that less than 90% meets our admission criteria. And the second is that if a patient's baseline is in the upper 80s, whether it's on room air or with their home oxygen, these are more likely end-stage COPDers and more likely to need subsequent admission or decompensate in our CDU. Obviously, no one with mental status changes would be a good candidate, and we do not take anyone with any non-invasive positive pressure ventilation, although if they started with BiPAP and they've been weaned off, they would be fine to come up. And anybody with a comorbid condition of pneumonia, CHF, PE, or arrhythmia would not be a good candidate. This is our summary of our pathway. Again, we do use the combined COPD asthma pathway. It includes typical triad of interventions of bronchodilators, steroids, and antibiotics for our COPDers. We do include a smoking cessation here, and that does drop down for options for nicotine gum or for nicotine patches. And we also include a sliding scale that's really important to have for your diabetic patients in anticipation of hyperglycemia. One of the things that I also will stress is that if you look at our nebulized albuterol treatments, they all say Q4 hours. And that is because we want patients to get it around the clock, not just while awake, because we're really pushing to make sure that we can get them better as quickly as possible. In terms of our disposition, our admission rate is actually 20%. And there's the rest of our stats for fiscal year 2020. We do have a multi-collaborative approach for when we discharge patients. We have case managers that assist with home oxygen supplies and medications. They also assess for home care. We ensure that patients are going home on appropriate medications and inhalers. And if there's any issue with patients getting their prescriptions filled or follow-up or anything like that, we have two things. We make sure that the patients go home with medications in hand, usually a 1-month supply. And then we make sure that they have a follow-up appointment that's scheduled at least Monday through Friday. We actually have a scheduler that can schedule patients with their PCP, you know, preferably within a week. And if they don't have a PCP, then we give them one of our, we assign them one of our physicians. The respiratory does work with them to ensure that they get proper inhaler use or spacer need. And then everyone goes home with COPD instructions and smoking cessation if that's appropriate. I again want to highlight the fact that we do a ambulatory pulse ox before we assign a final disposition. Again, this is going to give us a good idea as to whether patients are going to fly well when they go home, or if they are going to need a little bit more time or even admission. So it's about time. And this is one of the reasons I wanted to pick COPD to review, is that really up until a few years ago, one of the only COPD observation unit studies was from a case series from 2007 that looked at a short stay unit and COPD patients. And now some great studies have just recently emerged. So first and finally, we have observation unit evidence for COPD. This was a large single-site study in New York that examined the impact of hospital admissions for COPD before and after opening an ED observation unit. And not too surprisingly for us folks that have opened observation units, it did decrease hospital admission for COPD patients by 13%. And they actually, if you look at this graph, you can see that there was really no significant variation in terms of seasons or month by month. Their median length of stay was 14 hours, which is right on benchmark. Admission rate was 53%. And an interesting finding was that their ED length of stay for patients that were placed in the ED observation unit decreased from about 9 hours before observation unit implementation to almost 5 hours. And if they compared it to the admitted patients, it was significantly less, as they were about 9 hours also. This retrospective study from Thailand that was great to see, first of all, observation units all the way in Thailand. This was a 15-bed ED observation unit, and really they aimed to identify any factors that were associated with treatment failure. And so they had 220 patients that were over the age of 40, and they found that 37% of this population had treatment failure, which they defined here as a prolonged length of stay, some recidivism markers, as well as morbidity, mortality. And what they found is that there were some independent factors that were associated with observation unit treatment failure. Namely, and the odds ratio here is on this right-hand side. If patients had baseline short-acting beta agonist use or long-term oxygen therapy, they were independent factors. If they also had any comorbidities of arrhythmias or diabetes, or had pneumonia or an ED length of stay that was less than 4 hours. So in terms of inclusion-exclusion criteria, there have been some recent papers exploring machine learning and how we can automate basically risk stratification and triage. So here are two papers I'm going to go through. In the first one, they used 2007 to 2015 National Hospital ambulatory data to derive 4 algorithms, and then they compared these to ESI scores. And ESI scores have really not been shown to be that great for COPD to begin with. And what they found is that the each of the algorithms had higher discriminatory ability to predict critical care outcome. You can see these ROC curves here, and especially, and even more so for hospitalization outcome. In the second paper, they used physician input to actually teach the machine and improve the algorithm. So it's nice to know that you still need a human component, but what they did was they used the physician input, and it was 9 pulmonary doctors, critical care specialists that facilitated kind of 3 aspects of the algorithm. So they adjudicated, for example, which factors were important clinically, and then they came up with test cases and then picked out which variables were important for identifying both COPD exacerbation as well as triage. And triage they defined as, whether the patient was able to stay home, whether they needed close follow-up in 1 to 2 days, needed to see their doctor right away, or whether they needed to go to the ER. And what they found is that machine learning was better able to identify an exacerbation when compared to a consensus, as well as each individual physician, with more accuracy, and especially in identifying triage. This is just some very interesting data on machine learning, and I think we're going to be seeing more of this. When putting together your protocol and pathway, one of the very useful resource is using GOLD guidelines, which is the Global Initiative for Chronic Obstructive Lung Disease. These are just some of the recommendations from their 2020 report in terms of systemic steroids, antibiotics, the role of reflux and exacerbations, and then the importance of long-acting beta agonists. So this is definitely something totally doable for your COPD pathway. One of the mentions that's new in the 2020 GOLD report is the role of vitamin D. Well, we know that vitamin D assists in host defense functions in the lung, and now there's good evidence to link vitamin D deficiency, especially severe vitamin D deficiency, to an increased risk of pulmonary infections and exacerbations. And they found that it could actually be reduced by about half if COPD patients with severe deficiency, as defined here, could receive vitamin D supplementation. And so GOLD actually now does recommend all patients hospitalized for COPD exacerbations to be assessed and investigated for severe deficiency. I actually asked my pulmonary colleagues, and they have been using this and have been measuring vitamin D levels to assess for severity. So I think this is a possible kind of easier intervention that you can use in the ED observation unit. Again, something that's totally doable, and really does depend, I guess, on how fast the vitamin D level comes back. This study out of the University of Cincinnati just came out, and they looked at the impact of a COPD care bundle on ED revisit rate. And it was a team-based approach, and it was created by a multidisciplinary team. And what they did was this bundle included making sure that patients were on appropriate guideline-based COPD medications, that they received a 30-day medication supply of insurance-compliant inhalers on discharge, that they received personalized inhaler education, standardized discharge instructions, and then follow-up within 2 weeks. And using this collaborative approach to management, where each of the team members, you can see respiratory, pharmacy, case management, they had a specific role in this process. And what this did was decrease their 30-day all-cause ED revisit rate by almost 40%. And they also found that, during this process, they had a bundle adherence of about 90%. So again, the COPD care bundle, I think, is something that's doable and that you should consider for your intervention piece of your pathway. These same folks, they were hot this year. They out of University of Cincinnati just this year, they did a 2-part study. And first, they retrospectively evaluated clinical predictors of safe discharge from their ED observation unit, and they defined their safe discharge as mentioned here. And they really found that none of the clinical predictors were predictive. or the variables were predictive. For the second part, they prospectively examined whether the resting Borg scale, which is a widely used dyspnea scale, whether this could safely predict safe discharge. And in this part of the study, they scored the patients every 4 hours, which is kind of a novel use. They also compared it with their own scoring system that they developed, which I'm not really going to go into because there wasn't any significant improvement over the Borg. But all study patients also received their COPD care bundle that I just mentioned. And what they found is that although patients started with very similar Borg scores, you can see here, they found that an improvement of greater than 2 was an indicator of safe discharge. And especially if they use a predisposition, so prior to ED observation unit disposition, if it was their Borg score was less than 4, it was actually an independent predictor of safe discharge. And if you look at the AUC, it was about 0.77. Just as a comparison, the AUC for a heart score in predicting 30-day MACE is pretty similar. So again, something that's doable, and actually there's a nice little dyspnea scale with some emojis that you can use. So just a quick word on COPD and COVID. The risk for severe COPD infection is, you may know, is increased by 5-fold or even higher in patients with COPD. And this summer we've been introduced with a lot of good evidence to show that the benefits of continuing inhaled or oral corticosteroid treatment outweigh any uncertain risks associated with COVID. And this is what Gold put in their 2020 report for COPD and COVID. I wanted to share our ED-CDU protocol that we developed with pulmonary respiratory therapy and pharmacy. And since our inhaler therapy was significantly reduced during COVID, we really used a lot of MDIs, and a lot of providers were mostly used to using inhalers because that's 99% of what we use in the ED for an exacerbation. And so we wanted to give them provide an algorithm that we could use consistently with MDIs. Treatment only for exacerbations, and then in the case that there was no MDI available, using terbutaline as a replacement. And we came very close, actually, especially one day I think we had to revert to this, but we came very close to having some days without any MDIs available. And so this is also the one that we used for our asthma, which included epinephrine and terbutaline. So thank you very much. I am always available, and please feel free to email me at any time. If there are any questions, or I know we're running a little short on time, I'll end right here. Thank you very much.
Thank you so much, Dr. Pena. I think there are some questions. We can maybe just answer them in the chat so we can kind of keep going on to our next topics here. So we're shifting gears a little bit and talking about more complex and unique pathways and protocols. So we're going to talk a little bit about mental health, behavioral health, and psychiatric observation, as well as geriatric observation. First up is Dr. Leslie Zunn. He is Medical Director of Lake County Health Department and Community Health Center in Lake County, Illinois. Also is Chairman and Professor at the Department of Emergency Medicine, with an appointment in the Department of Psychiatry at Rosalind Franklin University of Medicine and Science and Chicago Medical School. So we're very happy to have Dr. Zunn here to talk to us today. And as he is getting started, hopefully we'll have also Dr. Lauren Sutherland, who is coming to us from Ohio State University School of Medicine. Where she's, oh, go ahead.
I'm sorry, Matthew. I'm ready to go if you're seeing my screen.
We're not at this point.
Well, let me try that again.
Certainly.
Share.
There we go. Perfect.
Let me pull it up here and enlarge it. And if you guys are ready to go, I'm ready to go. Thank you.
Yeah.
Okay. So thank you for that wonderful introduction. Yes, I have a psych interest and has had it for a long time. And what I want to talk about this morning is really how to set up a psychiatric observation unit. Now, some people call it crisis stabilization unit or psych ED or whatever, but we all know that we have lots of boarders in our emergency department
Dr.
that.
Dr. Sutton, sorry to interrupt. I don't think we're seeing your slides. I don't know if you need to move them to the other side of the desktop or if you've started. Yep, there we go.
So I'm sorry, are you seeing them now?
Yes, we are. Everything's great.
Okay, great. I'm sorry. Okay, so I'm going to talk about how to set up and manage a psychiatric observation unit. And everybody knows that, or most people have issues with psychiatric boarders in their emergency department. And so I'm going to talk to you about how to make money on them, you know, how to actually turn that into a benefit rather than a liability. So I'm going to talk about understanding the admission criteria, how to review what the needs are to start a psychiatric OBS unit or a crisis stabilization unit. We're going to talk a little bit about finances as well. So this was an interesting study that a friend of mine did, Dr. Zeller, out in Alameda County, and they looked at what is the effect of regionalizing an acute psychiatric care facility or a psych ops. And what they did is they took patients from 5 EDs and they brought them to a centralized location to do psych ops, which was basically 24 hours or less. And when they looked at all the patients they were getting over a 30-day time period, they found out that the average boarding time was 1 hour and 48 minutes. So as soon as you called them and said, I have a patient I want to send to you, they say, okay, send them right over and we'll do everything else. And out of that group, after 24 hours of observation, only 25% needed inpatient admission. So we all deal with this issue of the log jam of patients who need inpatient psychiatric care. But in fact, if we utilize an acute psychiatric care or psych OBS, we probably could send home 75% of those patients rather than admitting them. So we just talked about reduction in admissions, with that benefit, gain in early functional independence. What we try to do is when they're in that psych OBS is to set up all those resources, outpatient care, whatever support services they need while they're there in that observation. We used a lot of community resources as well. The program that I set up, that as soon as they were discharged, they would actually go into a living room to transition out and get picked up by their relatives. It is, you know, rather than sitting in the ED doing nothing, getting meds to be calmed or sedated, they actually are being treated and evaluated and then many sent home. So, and it also is a better way to coordinate that care so that the patient gets, you know, all of their needs met. So many of the programs have a medical evaluation or ED evaluation plus a psych evaluation, and then they get psych treatment, which is primarily psych meds. They get restarted on their meds while they're there. So if we're thinking about doing psych observation, what are the kind of things that we need to make sure is in place? So I'm going to say that we can't mix medical OBS and psych OBS. It really has to be a dedicated unit that focuses on the patient's needs for psychiatric care. You need to set up good inclusion and exclusion criteria. We'll talk about that. You need to have an appropriate physical plan. Again, not, you know, you need it somewhat controlled. You need to decide if it's going to be a closed unit or an open unit. And usually those units are much different than medical units because they'll have a shared space or a living room area or a place where other patients can socialize. Important to start treatment protocols, just like what you do in a medical ED or a medical OBS, like for chest pain. The difference is you need to make sure that you have good security arrangement, and usually that means staffing it with a security person and some safety measures or alarms that may be necessary if there's a problem. You need to have both psychiatric resources to put in the unit, and we'll talk about that, as well as referrals out. So if you're going to send them out, can you get them follow up in 2 days or less than a week, or is it going to take 3 months to get them psychiatric follow up? And you need to know what community mental health resources you have so you can refer them to those. So here is just a sample of admission criteria. You want to deal with adults. Kids are much more complicated and really should be done by PEDS folks or PEDS EDs. They have to do their own activities of daily living, meaning that they can, they can toilet themselves and eat at a table. Treatment criteria, what are easily treated: psychosis, like your schizophrenics, depression, mania, like your bipolars, suicide ideation. Now, if they have truly high-risk suicide potential, they should be in an inpatient unit and not in psych obs. But if they're one of those moderate zones of suicidality, this would be an appropriate environment. They need to be medically stable. They need to have some insight into their condition, because that way they will be working with the provider and taking their meds and doing some therapy while they're there. They need to be somewhat cooperative and compliant with staff direction. And if they are aggressive, that it can be properly managed. If they're too aggressive or truly homicidal, that's not the kind of patient you want to put in this unit. Some exclusion, if they actually are or actually have a plan to self-harm or to hurt someone else, we don't want to put them in there. If they have a history of fire starting or fire setting, serious criminal background, they're going to use this as a means to get out of their criminal issues, and you don't want the police there watching them. So no one in police custody. If they're clinically intoxicated, probably it's best that they're a little more sober, but some units actually do the folks that have a substance use disorder and a psychiatric disorder. You don't want patients with delirium or overdose. That is not the right environment for these patients. So when we talk physical plan, and I'll show you an outline of one physical plan, you need to make sure that you have it in a comfortable location. A lot of places just convert old inpatient space. If you have the luxury of building one, great. Most of the time, they use lounge chairs or those cardiac chairs that will actually lay down so they could sleep if they want to. You need to make sure you have all that safety precautions, that all the sockets need to be properly covered or wired. They should be safety searched while they're in the ED, meaning going through their whatever they brought, and also when they come up to this unit or go to this unit. Most designs have a living room style where they're all kind of hanging out, but you need an interview room and a medical evaluation room. This is a proposed unit that we had been working on, and what you see, it's an old converted inpatient unit with some inpatient beds. Many of them have been opened up, and you'll see this large group room, a nursing station that has basically good visualization. And there's also a therapy room where they can go in and get group therapy as well. This, of course, would be in the post-COVID era as well. So, again, it's like planning out any OBS unit, but this one's a little more complicated because you need to make sure that your exits and your entry points are secure. All right. Staffing, probably not the ED nurse per se, unless they have a background in psychiatry or behavioral health. You want a psychiatric nurse. You want some mental health workers, and we'll talk about ratios. Most of the models that I've dealt with have advanced practice providers, the APRNs or PAs, that are trained in psychiatry or have expertise in psychiatry. And so you keep your costs down by having APRNs and a psychiatrist. And I will say, you could have the right emergency physician as well doing this. And you need to make sure that they have good training on verbal de-escalation and what to do with violent patients in case that comes up. Treatment protocols, it's important that you develop the protocols. How are you going to treat depressed patients, agitated patients, psychotic ones, manic? And so just like you would have protocols for chest pain, you want to develop protocols for common psychiatric diagnoses that would go into this unit. Now, we do know that there is about a 75% co-substance use disorder with psychiatric disorders. And for some patients, we don't know, is it the drug or is it their underlying psychiatric condition that's causing today's problem? So here's an opportunity to kind of let the drugs and alcohol wear off and see what happens. You know, this is that issue of the drunk person who always says they want to kill themselves when drunk, but when they're sober, they don't say that. And so this might be an environment to make that differentiation. You can observe them for their mild or minor intoxication, as well as you could be treating minor withdrawal. And you could start Suboxone if you wanted to and start your Esprit in this unit. So, and most of the treatment is really focused on restarting their meds or starting psychotropic medications. You want to involve social work and case management and discharge planning as soon as they hit the unit, just like you do in a medical one, to ensure that when they're ready, you have a place to send them to, you have follow-up for them, those kind of things. When I looked at other crisis stabilization units or psych obs, they don't do a lot of other therapy. They do some talk therapy and problem solving and things like that, but it's not heavy on therapy. And again, you want to involve the family as much as possible to help this support and a support system when they go home. Some units are also involving peer and peer support assistance while they're there, and of course we want to connect them to other services. Reimbursement is a challenge for some places. So Medicaid usually pays about $100 an hour, a maximum of 20 hours. There is a crisis stabilization code that can be used. Again, it depends on your state. This is the code from California. Medicare, there's some question about whether they will cover this unscheduled psych eval or not. But some private insurers do cover it because they see that if they put them in a psych obs, that in fact they may not have that huge bill for an inpatient stay, like I talked about earlier. So when we look at payment, it's interesting that state by state, it's variable, and that, you know, Kansas started the payment for psychiatric observation, and they actually will pay up to 3 days. So some places actually do not 24 hours of psych obs, they do up to 72 hours of psych obs, and New York is a typical example of that. In Illinois, where I'm located, there was a time when they were paying $27 a day for psych obs. They have since changed that, and I think it's back up to about $800 per day. And California is about $100 per hour, and this is really based on Medicaid payment rates. So, well, let's just spend a couple minutes talking about what revenue and expenses looks like, and you know, if we look at this one model, and again, these numbers are made up. They are not numbers from a specific psych obs unit. So if the physician doesn't see every patient and does some observation, the average would be about $20 of reimbursement over the 6, and it's based on a minimum of 6 patients, and the staffing's based on a minimum of 6 patients. And if you have more, then you're actually going to look at more money. And you can see professional fees will bring in maybe a little over $300,000, and hospital fees will bring in about $2 million for 6 patients, an average of 6 patients per day. So you have the potential revenue of about $2.4 million. If you look at cost estimates, and depending on your location, the psychiatrist may make significantly more than this. You only need a psychiatrist about half time, a nurse practitioner about $40-some an hour plus benefits, and you need about 2.5 of them. Now, what this is based on is you probably don't need a provider there, a psychiatrist or nurse practitioner 24/7, but probably more like 18 or 20 hours a day, because most of your patients will need at least one psychiatric evaluation, if not 2, and you can kind of schedule those. You'll need psych nurses, you'll need a psych tech, and a public safety officer. And this is based on a one-to-one psych RN and mental health worker. So your expenses, and this doesn't have all the overhead expenses, is about $1 million. So as you can see, there is potential to make significant amount of money to do psych obs. And of course, you don't get, now, if you do keep the patient in the ED and you provide the same level of psych ob services, you could bill for those psych ob services, but it does have to meet the same kind of standard that they would get in a psych obs. So when we talk about fiscal impact, the reimbursement is based, of course, on the observation rates, and if you could get a deal with your HMOs or your ACOs to preferentially send patients there, that is quite a benefit. There's a reduction in the psych boarding time, so you have bed turnover in your ED. And so you have the potential for revenue enhancement. Again, this would be more so in the post-COVID era where we're seeing those increased volumes again. So potential obstacles. Now, remember, you know, you're stealing from Peter to pay Paul. So if you have a psych unit that's not staying full, an inpatient psych unit that's not staying full, then maybe this isn't the best option for you. When you look at the finances, it's really going to be based on what your reimbursement is, primarily from Medicaid. You need to know if you have support services available. You need psychiatrists and mid-level psychiatric providers. So if they are available in your community, then you can think about it. If they're not available, then it's really quite a concern. So kind of lastly, what are you waiting for? Is it time to start a psych obs unit? You need, you need some time. From, shortest time I've seen is 9 days, but probably more like 6 months. You need space, you need to hire the personnel, you need to make sure you know what psychiatric services are available, what community resources are available, and develop your policies. And I will be on for questions, but if someone wants to communicate with me instead via email or call me, there's my information. And I want to invite everybody to our conference. The American Association for Emergency Psychiatry is not going to be in Vegas this year, but it's going to be virtual. And with that, thank you so much. And Matthew, whether you want to do questions now or later or move forward, whatever works for you. Thank you.
Thank you so much for your presentation. Why don't we, I guess, hold questions now, or if you maybe could address some of them in the chat box while we kind of move on to the next presenter, just for the sake of time. So our next presenter is Dr. Lauren Sutherland, who's an associate professor of emergency medicine at Ohio State University, and is also an expert in geriatric ED and geriatric observation. So we are happy to welcome her today.
Hello. So, give me a second and hopefully this will present correctly.
Looking good so far.
Nope, doesn't want to share the presented one. Okay. We're just gonna have to look this way. So, many of you may know that I love geriatric patients and that they're my favorite patients to care for, but you may also not know that I also love baking and I have a huge sweet tooth. And while I like to bake, I would probably never win the Great British Baking Show. I might be able to pull off Nailed It if you've ever seen that show. So I'm going to describe to you how to make your department geriatric friendly via cake. So we're gonna start with, let's assume that your 6-year-old daughter asks you for unicorn cupcakes for her birthday party. Well, you could go to the grocery store and pick this up from Meyer or Piggly Wiggly or whatever and say, all right, unicorn cupcakes, job done. They meet all the criteria. It was a unicorn, it was a cupcake, I'm good. But what's the difference between that and what your daughter really asked for, which is this? You know, she wants something that looks good, delicious, that you took the extra time and maybe even got help from someone else, whether it be a YouTube baking show or something else. And luckily for all of us, we have a place to put patients who need a little extra time, right? Where do we put them? In observation. So it just all makes sense. So why do we think about older adults in observation? Well, because you're already seeing them in your ED. And this is the national NAHAMSIS data that you'll see that 1 in 5 patients in EDs are older adults. But what you see with that is even though it's 1 in 5 that walk through your door are older adults, they're taking up a disproportionate amount of time. What I tell my residents, I'm teaching them, is an older adult is never an ESI level 4. If you see an 85-year-old that's triaged to 4, it's wrong. Even if they're there for suture removal, it's still more complicated than for a younger patient. And what we do see nationally is they're more likely to be admitted and more likely to put into your OBS unit. And when they're put into your OBS unit, they're there for different reasons. So younger adults, everybody's there mainly for symptom management, and because that comprises all sorts of ICD-10 codes like nausea, vomiting, abdominal pain. Younger patients are there for a lot of cardiac workups, drug abuse, and COPD, whereas older patients, you'll see disease of the urine infection, metabolic and immune disorders, a lot of diabetes and other things, so more complicated protocols and complicated things. So they're there and they're more complicated medically. They're also more diverse, so they can be from all sorts of different places. You know, when you think of a 25-year-old previously healthy, you think, okay, they probably are independent in their activities of daily living. But when you think of an older adult, even if they don't have many things on their medication list, you still got to think of what resources they have at home, where are they coming from, and where are they going. And we can have a whole nother talk on that sometime. So a lot of what you need to do out of the OBS unit is a lot of transitions of care. And Margarita talked a little bit about that on her COPD talk about making sure they have the medications to go home with, that they can afford their inhalers, that they have PCP follow-up. So you're already thinking about that and doing that for your patients. I just want to give a little older adult spin on it. So to give an example, I'm going to tell you about Mr. Y. And you have all seen Mr. Y in the ED because you're all fantastic emergency medicine docs. And Mr. Y comes in, he has this chest pain. By the time he gets through triage and is placed somewhere and he's had a negative EKG and you get all the workup for him, and all the basic labs are fine, chest x-ray is fine, you get a delta trope and a D-dimer, and by now he feels fine. The only thing you can find is that his blood pressure was a little high when he came in, but after giving him his home evening meds, it came down just fine. So I'm going to do a little show of hands here. So if you could hit your reaction emoji, I want everybody who would send this guy to dispo him to home right now, give me a thumbs up. All right. A few people, okay. I mean, this is standard of care. You did his heart score, you did his delta trope, he's had a cardiac cath recently. I figured the board would be lighting up. There we go, lots of thumbs up. So, so thinking about that, what I want you to do, and you just made unicorn cupcakes. You hit all the boxes. It is a unicorn, it is a cupcake. But what I want you to do is take a little more time and say, dig into his history. And what model I use is something called the 4 M's. So you made this cake, okay? And I have made this cake before too, not this exact one, but you know, you tried. All the elements are there, but we're gonna take a little more time. So when you dig into the first M is mentation. How is he really thinking? And when you really challenge him, any question he'll answer. He'll talk to you for days if you let him. But when you really challenge him on the date and time, he confabulates. He says, I don't know, I'm retired. And then a quick screening test that I do is just 5-minute recall. So you give the person 3 words to remember, hopefully 3 words that are easy to pronounce and not derogatory or demeaning in any fashion. The typical is apple, table, and penny, but you can pick 3 words that you like. And then you have them repeat them for you and make sure they know and say, I'm gonna ask for them later. Are you gonna remember them? Yeah, I'll remember them. Then ask for them a couple minutes later and you'll see. So if they can't remember something from 2 minutes ago or 5 minutes ago, how is he gonna remember whether or not he took his meds that night? How is he gonna remember the symptoms you're telling him to come back for? And fluency is another quick test. So these are geriatric things, but these are little things you can do. And there are lots of quick cognitive screens for the emergency department. So he's got some cognitive difficulties. And then when you ask him about his medications, which is the next M, he tells you, oh, I take all my meds, doc. But he can't tell you what he takes. And some patients can't remember the name, but they'll say, you know, it's a little blue pill I take in the morning and then 2 at 2 o'clock and some in the evening and one ends in Pril. So those patients I'm not as worried about, but when they can't tell me when they take something or what the names are and he says something like, I take what they send me, doc, then I get really worried. And with medications in older adults, you also have to ask about over-the-counter medications and substance abuse. Because I have been told by many patients that drinking is fun, and so they like to do it, or they've been doing it all their lives. So, and people aren't going to volunteer that they drink 4 to 6 beers a day to you unless you ask. So the next M is mobility, and he goes, yeah, you know, I haven't fallen recently. I don't use a walker or a cane. Well, this may surprise you, but patients lie about whether or not they've fallen and whether or not they get around well because they're worried you're going to put them in a nursing home or they just don't remember. We already know he has cognitive difficulties. So you have to do some sort of functional test to get them up and walk them. And that could even be asking your nurse, how did he get to the bathroom? Was he able to get out of bed easily and walk easily? So the nurse noticed that he got out of bed just fine, but then he was kind of unsteady. And then when you press him on it, he kind of holds onto walls and things. That's called couch surfing in a different way, not from home to home, but when you hold on all the different furniture. And when you're thinking about this transition of care, is he good to go home? You realize that he's trying to manage everything on his own. He's got cognitive difficulties. He's got drinking issues. So now I hope you'll say, I don't think this guy is safe to go home. If I send him home, he's going to come right back hypertensive again. And maybe the next time is the big time, or he's going to have a fall and get a subdural from his alcoholism. So he needs more time, he needs more assessment. And that is how we go from this kitty cat cake to an excellent kitty cat cake that we would all be happy to have at our Halloween party. Okay, just that added thinking and added time. And you may say to me, Sutherland, I don't have that time. I can't do all of that. That's how you do it in observation. So I can say, yeah, maybe I don't have time to do all of that assessment in the ED, but I can place them in observation and I can get my friends to help. And that's how you can use your observation unit to become geriatric certified and accredited. So I might do a quick cognitive screen, like I said, can you tell me 3 words a minute or 2 later? And if they're not doing well or they're a little disoriented, some places have a trained geriatric nurse practitioner who will come down. We consult our inpatient geriatrics team, and they'll see people in the obs unit and say, yeah, this person really doesn't have capacity to make decisions. They're really confused. They probably have either alcoholic encephalopathy or dementia and needs further workup. And that changes your disposition entirely, right? You were going to send this guy home, and now you have a certified geriatrics opinion that they need a full capacity assessment or placement. So bring your consultants down. You could have him assessed by physical therapy and occupational therapy. And maybe he just needs some outpatient PT to help, or maybe he just needs a cane to walk with. So often we get these people home, but getting them that extra assessment or home health PT set up out of the OBS unit can make the difference between life and death for people. And that's what I want to reinforce. Is our ED care does not keep aligned with what older adults want. They want to live happily and safely in their own homes. And when we just rule out life-threatening things and send them back, there are other life-threatening things we miss in our basic cardiac workup, our basic TIA workup. You got to think about their home situation, their fall risk, their nutritional status, and where to go from there. And so having this big team helps. The other component of a geriatric ED is not only the ability to have this multidisciplinary geriatric assessment with geriatrics expertise, physical therapists, a pharmacist med review, calling his pharmacy and seeing what he's supposed to be on and actually talking to him about what he's taking, and then a case manager. So I'm hoping that most of you who have established OBS units have FTEs of case management in them, but our case management OBS unit is indispensable. And I love them so much. And they will go in and do a whole home safety review. Where do you live? Who lives with you? What kind of place is it? What resources do you have? What resources of the community can we get for you? You know, I've had patients with CHF that what they really needed was not their Lasix adjusted, but Meals on Wheels sent to their house because they weren't getting enough good, healthy food and they were eating crap. And that was putting them into CHF exacerbations. And then the second piece of this is equipment. So having walkers and canes for them to use when they're in your ED, having just pocket talker or hearing aids to help with. And all this is easy to do and not very expensive, I promise. So you may say, well, I went to my administration team and said, I want a physical therapist station in the ED, and they said, no way, Jose. But the thing is, you don't have to ask for extra staff. You just need to use the staff that your hospital already has, because you can consult the inpatient PT team to come to your OBS unit and see the patient, and they can bill for it as an outpatient visit. So our PT and O team billed over $1 million last year out of our observation unit. So they love us and they prioritize our patients to see them first. And we just recently wrote an article which I'll link to you or send out to you about how to bill for all these different things. A geriatric nurse practitioner, they can bill to see your patients as a geriatric consult. So our geriatrics team, when they get a consult from the ED or ED OBS unit, they come see us first so we can make a disposition decision, admit, OBS, send home, whatever we need to do. So you build these relationships and you don't need to hire extra staff. You just need to have a relationship with your hospital staff. So the cost of equipment is really minimal. You can see this is our actual first year costs for our geriatric ED. And we got about 15 walkers and canes and things. It's not that much, under $5,000. We have these little sound amplifiers or pocket talkers, reading glasses, some cognitive things. And it looks like this. We have this cart here that's filled with all the tools, and there's our wall of walkers and canes. So when I started at OSU, we had 1 walker for a 60-bed ED. Now we have 2 stations like this for an 82-bed ED. And the nurses say we want more because they love to leave them in the room with the patient so they don't have to go searching for it, and the patient can get up and use the bathroom or ambulate to procedures and things easily. So getting back to the concept of geriatric ED accreditation, the whole rationale behind this is to point out that some EDs are trying to do more of this work and be better for their older adult patients. And they built it as sort of a trauma system where level 1 is the highest and level 3 is the lowest. And level 3, all of you can get. It is one QI project and one doc and one nurse that are interested in geriatrics. So you've done some geriatric CME and you've done a QI project, and that can be getting physical therapy to your OBS unit, okay? As you move up, level 2 is you're doing 10 different things. So that might be doing some fall risk screening, some cognitive screening, having a case manager there to assess people. And then level 1 is 20 different things. And level 1 is having that capacity for the multidisciplinary geriatric assessment. So we have, as a level 1 ED, a couple of different protocols. We have a geriatric kind of frailty protocol where they get this multidisciplinary assessment, and then a fragility fracture protocol where if you have someone who doesn't have an operative fracture, so we do a lot of compression spinal fractures, acetabular or non-operative pelvic fractures, distal radius or humerus fractures, and it's just so much better to have them see PT and OT and make sure they have a good pain plan and see what needs they need for home before they go home, and that takes time. So that's your 8 to 24 hours right there in OBS, managing a fracture that a lot of people would just split and send home without all these other resources. So you can do this better. And again, if you're almost to a level 2 geriatric ED to silver level just by putting in some policies in your OBS unit. Have 3 order sets, being able to have a pharmacist do some med rec, some sort of standardized fall assessment, and ability to consult physical therapists, home outreach programs, more transitions of care, which many of you already have in place for your ED. And what we found was that putting these types of things in place, they're not just used for the older adults. It's not just the 85-year-olds who need this. It's the sick 55-year-olds. It's the cancer patients. There's a lot of younger adults who benefit too. So the fun part about doing geriatrics is everything we do to help older adults helps everybody in the ED. There's really no downside. It just takes some time and effort and education. And with all of that, you can put everything together and make a beautiful rainbow cake, and the world is all better, and your patients will thank you. Families will hug you. And instead of sending Mr. Y home to then fall and have a subdural and die next week, you will get him the care he needs. Okay. Thank you, everyone. If you have more questions about how to design a geriatric ED, ACEP has a website with a lot of information. You can also email me, and I'm happy to answer quick questions. I've also done formal consults for people where I've gone to their institutions and looked through their OBS unit and their flow and everything and written up reports for them on what they can do. So I can help in a lot of different ways. I've been doing this for a long time. Everybody on the geriatric accreditation team wants every ED in the nation to be accredited and to be doing great work for older adults. So we're here to help out. Okay.
Thank you very much. That was great. I have now a list of things I need to go check in my own ED, and strangely want some cake now too. So
yes, it's bad that you put me on before lunch.
There's some great questions and discussion in the chat, and if you wouldn't mind addressing those so we can move on to our final speaker of the morning, who is somebody who both needs no introduction, but also if we were to do a proper introduction for him, it would take the rest of the morning. Dr. Peacock is one of the lions of the specialty of emergency medicine and also observation medicine. His list of publications is tremendously long in neuro and cardiology, as well as other areas. He's professor of emergency medicine and vice chair of research, director of research at Baylor College of Medicine. So we're always lucky to get him to speak at our conference every year. So we're welcoming him back again. Thank you very much, Dr. Peacock.
Thank you for that introduction. That was really nice. Can you see the right slide now? Wait a minute. Now can you see the right slide?
You can see your pictures, not the desktop yet.
Okay, good.
There we go.
So I'm going to talk about radar and magnetic resonance imaging in the emergency department, which we don't usually normally think about that, and certainly not in the obs unit. So go slide. I have no disclosures. I wish I had some disclosures. I can't make the slide advance. There we go. So I'm going to start with shortness of breath, because this is how we think about heart failure. There's 141 million ER visits. It's estimated about 2% of them that show up in our department are due to shortness of breath. So that's 3.5 million a year. It's a lot of it. And the reality is that when patients come in, it'd be nice if we could get the diagnosis right. And dyspnea is like chest pain. It's like all the other important stuff. There's a whole bunch of it. I think of it like this, like a pie. And there's this many of them that are a whole bunch of different stuff, of which that one on the bottom is heart failure, and that might kill them today. And so they never come in that way. They come in with shortness of breath, and you have to sort it out among stuff that's absolutely trivial, anxiety and things that won't kill them today. I'm not going to make that as it's trivial, but they won't die of that. Or it could be heart failure or an MI. And so we have to sort it out. It'd be convenient if they came in with a tattoo on their forehead, and because you know what this guy's diagnosis is. And this lady who's 100 and smoking and short of breath, well, she's probably pretty easy too. But that's not really how they come in. And I want to show you why this is important. It's one of my favorite trials. It's an old trial, 92. This was 8,300 EMS runs, of which 499 were later adjudicated of heart failure. And if the EMS guy thought you had heart failure, you got nitroglycerin, morphine, and Lasix. Now, I'm not thrilled with morphine, but it's what they did in those days. And that's what you got. And if you didn't have heart failure, you did whatever they wanted, which is generally aerosols. 240 of those heart failure patients got treated and 250 did not. If you got treated, it took 1.9 minutes longer on the scene, but you got your treatment 36 minutes earlier because you didn't have to wait till you got to the hospital. So not much of a difference. But if you were treated, your odds ratio of survival was 250% higher. So that little 36-minute window was really good. Now, one of the things there is that if you look at the mortality in this trial, it's 11%, which is extremely high. Most heart failure mortality is about 2% after they're admitted to the hospital through the ER. So this is a sick population, but in sick people, early treatment really works. And why don't we do more early treatment? Well, because we don't always get it right, that's it. And there's another piece to this same trial. They looked at the people who didn't have heart failure, but got heart failure treatment. Because one of the take homes for this, you could just treat everybody for heart failure if the time is so important. But the reality is those people who got heart failure treatment who didn't need it, their mortality went from 3.8% because they were treated with bronchodilators to 13.6% because they were getting heart failure treatments, not bronchodilators. That mortality increase is 250%. So it's a 250% increase if you treat them, decrease if you treat them early and you're right, and it's a 250% increase if you treat them early and you get it wrong. So getting right is really important in sick heart failure patients, because essentially, if you're not getting it right, you're just deciding who's going to die. This is the problem, and this is the continuation of heart failure. We know this from putting implantable devices in people, that about a month before they come in decompensated in heart failure, they have pressure and volume changes you can measure. But I'm an emergency doc. I don't ever get to see that. I can't even interrogate their frickin' pacemaker half the time. And that occurs over time. About 2 weeks before it, you can actually measure thoracic impedance increases, but that's 2 weeks before they get in, and weight changes that happens in the last week, and then they show up in my ER. The problem is all these changes occur really late, long after the window of me doing something. And so the question is there something we can do? And this truly happened to me about a decade ago. I'm sitting in my office, I talk to heart failure people all day and cardiologists and that sort of stuff. And this guy from the Israeli Defense Force walks in. He's a full-on army guy. And he holds this thing up to me and goes, "I'd like to talk to you." And I'm thinking, I didn't do anything wrong, honestly. It's the Russians. And he pulls this up and he shows me that he's got this device that can see through walls. And I go, wow, that's really cool. And he shows me that. And you can see the guy in the picture. And I go, wow, does that guy got heart failure? And he goes, that's why I'm here to talk to you. It's because his device doesn't just see through walls. And they use this for terrorists, right? They go in there, they look through the wall, and they shoot the guy through the wall, so they don't even have to go into there. But if you can see through a wall, you can see through a chest. If you see through a chest, you can see how much water in his chest. It's like, holy crap, that might really work. So that's how we got started on this. This is REDS. It's remote dielectric sensing. It's essentially radar for the chest. It's non-invasive. It takes about 90 seconds. And normal humans are about 20 to 35% wet, somewhere in that range. And if you're more than 35, you're probably full of water, and that's heart failure. And if you're under 20, you're probably bone dry and you could use a bag of fluid. This is the device. You can see it on this guy. This is not the device they gave me to study. My device was much more difficult. This thing is essentially a clamp. It goes over the right chest. They can wear their clothes and you let it sit there. This is the new device. So it only takes 45 seconds and it gives you the same numbers. And so you can see that dude getting his chest radar right there. That is the device. It has to match. This is the thing on the right there with the ABCD. It has to match their the right size of them. That's a sizer. But the whole thing is under, it's an under 2-minute intervention. And this is how well it works. This is REDS versus CT for volume in the chest. And CT is probably the gold standard for chest volume currently. There are other ones coming down the pike, not FDA cleared or available at the moment. But if you think CT is great, the problem is you take somebody who's really CT and who's really short of breath and you try to jam in the CT and you end up intubating them. So that's why we just can't do it. But if that is the gold standard, you can see that the correlation between the REDS and the CT comparison is pretty darn good. It's got a 0.9. The other thing it correlates with, which you would hope, is it correlates with wedge pressure. So you can see the rock curve there. It's a 0.85, so pretty darn good area under the curve for wedge pressure greater than 18. And so if you're wet and your wedge pressure is up, this has got a pretty decent correlation with the right reason. This is comparing all the other options we have. You can do weight monitoring. That just doesn't work, quite honestly. If they eat a pizza, their weight's up. And the other problem is people pee the bed and do things like that. So weight is not very accurate or useful. It's non-invasive and it's free, but it's not helpful. Impedance, I used a lot of this. I've published a dozen studies on it. The problem is the accuracy is questionable. And when you get a questionably accurate number and it tells you to give the patient a liter of fluid, it makes you really nervous and you won't do it. And that's why bioimpedance has really had trouble. Implantable sensors are outstanding and good luck. They're only $5,000 each and most people don't have them. And swans I'm not going to do. And we talked about CAT scans, which leads us to the radar. This is the device I used. It's a vest. It's more of a pain to put on. And then you can, and I'll have a picture of that in just a second, but it does the same thing as the new device. So we did a trial. You had to be 21. You had to be in the air. Couldn't be pregnant. Had to be short of breath. And we put the device on a bunch of people. And this is one of my fellows wearing the device. And you can see it's a little more fancy or a little more complicated than the last one. This is the earlier model. But it works really well. And then what we did is anybody who we put it on was short of breath. We had 2 emergency docs later, blinded to everything else going on, adjudicate the post-discharge diagnosis. And then this is what we got, 45 patients. And you can see the other group is the heart failure group. And then all these other reasons people have shortness of breath. And what we found out is if you use a physiologic cut point of 35%, you get a specificity and sensitivity of 7, 8, and 85. A negative predictive value 91 for heart failure. So it worked pretty good. And then we started, and what I want to do is put you into the orientation of what a BNP is. A BNP and a chest x-ray together get you to about 81% as an emergency doctor accurate. So, and it takes time. You have to examine the patient and actually talk to them, touch them, listen to them, and get a BNP. So this gets you a similar rate of accuracy at about 2 minutes into it at triage, and the nurse can do this. This is the ROC curve for that. Now we optimized the cut point at 37%, not 35%. And the reason we did that is because you can see what it does with sensitivity and specificity. Now you have a 90% negative sensitivity, which means 1 out of 10 false negatives. So when it says you don't have heart failure, you really don't have heart failure, which means who can you go home? Well, maybe they can. So our conclusion is it worked pretty well for that. And then we did another trial, just got this published a couple months ago. We looked at patients who came to the hospital, got hospitalized for heart failure, and then we measured the REDS at them when the doc said they're ready to go home and see what happens. If they were determined to be wet, they were consulted heart failure who gave them more therapy, and if they were turning to be dry, they just did what they were going to do. And you can see that about 32% of the patients the doc said, oh, they can go home now, were actually wet. So of that 32%, half got unblinded and the docs did the right thing, and the other half didn't get unblinded, they went home. And it turned out, so this is out of 180 patients, 32 will be wet at discharge. You know what happens when you're wet at discharge? You come back. You come back in about a week, which is why heart failure comes back so often. So the treatment arm got more diuresis. They lost an additional 5 pounds and they did not come back. If you look at the 30-day heart failure readmission rates, it was 0.2% versus the group that didn't get treated, and that's 4% of them came back. So you can do the math on that. That's a huge difference in coming back to the hospital a week later. That's 30-day readmission rates almost go to 0, goes to 0.2. So discharged with the dry reds worked really well. All right, the last thing I'm going to wind up here is my magnetic resonance imaging. This has been done before, and people think we can do this. That's actually a stress test machine in the right lower quadrant there of the slide, inside the magnetic resonance image, and that's a real pain to do, and it takes forever, and it's it's a half an hour test, and it's just a nightmare. That's not going to take over emergency medicine. You can get great myocardial blood flow estimations from the MR, and this is the actual image there. You can see they measure the pixels, and they can tell you how the flow looks. So it's a good quantitative flow test. So like a stress test, it's a flow-based thing. It's not a anatomic-based thing like the CT. This is a meta-analysis of 7,000 patients looking at sensitivity and specificity of coronary disease. It's pretty damn good. It's in the 85-90 range for sensitivity. So when you don't have it, you really don't have disease. And specificity is 75-85. So if it says you have disease, you probably do. This is, look in the right lower corner, that's the ROC curve meta-analysis of 166 studies looking at PET, CMR, and SPECT for obstructive coronary disease. And they all are, in my view of that, they're about the same. Yeah, there are small statistical differences, and PET and CMR on top of each other, slightly better than SPECT, but they're all pretty good at telling you you do or do not have disease. This is a couple other studies looking at the one MR impact and CE mark, and they both showed that SPECT was less sensitive for coronary disease than CMR. So CMR wins for sensitivity, and that's really what I worry about, because sensitivity is I say you don't have disease and I boot you out the door. If I accidentally call you false positive and you're not, there's less of a penalty because I don't send you home. We have more time to get it right. These are the images. You can see on the left, the MR has clear abnormalities. It should be a nice ring, and it's a messed up ring. Same thing with SPECT. And then ultimately the gold standard is angiography, and you all know what those look like. But this is the deal. If you have a negative CMR, you have really low event rates. And if you looked at the CMR is all the negative ones were all the hollow boxes. And you want to be the hollow boxes because those are death and non-fatal MIs. And they win across the board. This is 11,000 patients. So if you could do this in the ER, this might be cool. But I showed you that ridiculous picture. And this is if you follow them 4 years, the primary outcome CV death or non-fatal MI. And where you want to be, this is no ischemia is the low blue one. That's where you want to be. And if you have no ischemia and late gadolinium enhancement that's negative, you're going to be alive in 4 or 5 years. And if you don't have them negative, something bad will happen to you. And that's the purple curve on the top. So now this is where the ER comes in, is this is strain encoded magnetic resonance imaging. And the reason this is cool is because it is way faster than the old MRI, and you don't have to get a stress test, crazy thing. It's just an anatomic test that's looking at elastography. Does it work? Well, if you look at these curves, you don't want to be the dotted line. That's event-free survival, and you didn't have any. You want to be the top line where it's near 100. And so if your strain-coded MR is negative, you're pretty good for the next 50 months. So that's a good risk stratifier. That's only 320 patients. This is looking at that, but the difference here is this is one heartbeat data acquisition. So what's that take? A second? Yeah, exactly. It's a 1 second MR of your heart. And when you have that, we can now talk about, this might be an ER tool. And I'm working with the company right now to make this happen. We want to check about 1,000 patients and demonstrate that we can do an MR in the emergency department in under 10 minutes. And that includes the time you get naked and get onto the scan and get off and get your clothes back on. And that truly will rule this out. And this is the data that supports the fast strain coded negative predictive value. So radar, really good for volume assessment. You can use this today. It's out there. If you're dry and if you're under 37% and you can go home and you're not coming back for heart failure. You might come back because you're hit by a bus, but you're not coming back for heart failure. And CMR, now that we have a solution that is reasonable for emergency department flow, this could become the new gold standard. And with that, I'm going to wind this up. Thank you very much.
Great looking picture. Thank you so much. I know we have a couple questions in the chat, and I think we wanted to take a few minutes just to see if folks who are out in Zoom land had questions about any of the presentations this morning. These were great presentations, and I think if we were in person, there would obviously be more opportunity to have some discussion and stuff like that. I think we've run a little over, but I think we can take some time if there are some more questions or discussion out there. After this, we'll take a couple-minute break before we go into the next little bit. Just looking through the chat thing here. Which services for the cardiac MRIs? Which service is reading those?
Oh, that is definitely the MRI people. That is not me. The strain encoded ones, they actually have software that'll read it for you, but that's not validated yet. I still want my radiologist to be out there.
Right, and is that just like a chest radiology division, or did they have to bring in special folks and train them up, kind of like when you're doing CCTA, you have to, it requires a whole ton of infrastructure to put in place to get that read?
Yeah, you need one person who can read it. It's the software is really quite advanced, and so that's going to be handled by them. But but you don't need. It's not like CT where it's going to take them an hour to read this scan. It's much quicker.
Okay. All right. Excellent. Okay. Well, seeing no further questions at this point, we'll go ahead and take a couple-minute break. Let's reconvene at 12:10 for the next session.
Thank you much.
That's classy, sir.
Yeah.
All right, let's go ahead and, can you hear me okay? Okay, great. So I just, next up on my partners in crime that I would like to introduce, and both are part of the Emory Legend of Observation Experts. And they have a great review of the observation literature lined up for you. Dr. Matt Wheatley is the medical director of the CDU at Grady Memorial Hospital, assistant professor in the Department of Emergency Medicine at Emory University School of Medicine. And Dr. Anwar Osborne is double boarded in EMIM, medical director of the Hospitalist Medicine Observation Unit at Emory, and also an assistant professor in EM and IM at Emory University School of Medicine. So take it away, guys.
I haven't got a chance to talk that much, but I'm honored to be presenting like the kind of a rundown on the more recent literature with my colleague, Dr. Wheatley here. We've been working together for a long time, and so he's gonna start with a few kind of big topics, and we're gonna try to switch back and forth, and we'll switch the screen sharing responsibilities kind of as we go. So with that, Dr. Wheatley, please take it away.
Sure. Some of these I think are going to be, I guess, OBS adjacent, but it's always good to see stuff published in the literature that I think can inform not only how to manage people in the observation unit, but maybe can inform when to send patients to the OBS unit, and also how we treat them in the emergency department. So we're going to start by looking at a couple articles that deal with syncope. The first is the faint score. And if you look at the author list here, there's some familiar names. This was a large group that encompassed 11 EDs in the US. And they were looking at patients, specifically patients greater than 60 years. So they did this as a prospective observational study and looked at patients that after their ED evaluation had still unexplained syncope. And what their primary outcome was 30 days serious adverse events. And that was pretty broadly classified. So that was death, significant arrhythmia, new structural heart disease, or any kind of cardiac intervention within 30 days. So it was a kind of a broad characterization of major adverse cardiac events. And so in their initial study, they had a little bit under 3,200 adults. Their mean age was 73. 5.7% of them had primary outcome. Interestingly, the most common outcome was SVT, symptomatic SVT. And so, hearkening back to Dr. Sutherland's talk, you may say, well, SVT, that's not so much of a bad thing, but, if this is an older adult and it's somebody that their symptomatic SVT is causing them to pass out, you probably do want to identify that and get that either treated, or if they need to have a, defibrillator placed or a pacemaker, or see cardiology or get put on medications, it's better to kind of identify that than to send them home. Anyway, they used, from their group, from their patients, they used Bayesian logistic regression to derive the faint score, which you can see projected here. And they actually found that if you had a faint score of 0, it basically excluded serious cardiac outcomes. And they found this to be superior to unstructured clinician judgment in terms of finding people who are at low risk. And you can see that kind of here. So, you know, the obvious thing for this is this needs more validation before it can be widely distributed. But, you know, the thing I kind of take away from this is, you know, these are patients that we, you know, patients with a faint score of 0. So if you know, no history of heart failure, arrhythmia, and you have normal workup in the ED, essentially, you know, maybe these are people that can be sent home and don't necessarily need to go to the OBS unit for, you know, the gold package or the platinum package of the, you know, stress and echo and tilt table and all that stuff. So more to come on that, but it's definitely interesting when you see that. There's a second paper that was published with the same authors, many of the same authors, and using kind of similar data set. And what they were asking is, you know, essentially what is the, you know, what do we see in terms of abnormal lab results in these older adults who present to the emergency department with syncope? So they had kind of same cohort, around the same number of patients were in this group here. And what they tended to find is that, you know, patients over 60 had or abnormal lab results that would suggest, you know, dehydration and or anemia, maybe as causative or contributory to their syncope, which brought them to the emergency department. They found these lab values in about 1 in 25 patients. And their take-home point was that, you know, very basic studies in the emergency department, just a CBC and a BNP, can identify these non-normal lab values. So, you know, again, without historical or physical exam features pointing you to a serious cause, that just doing kind of a basic workup can rule in or rule people out for serious causes. So a couple good, interesting syncope things here. And I'm going to...
Well, let me ask you a question, Matt.
Sure.
Like in the Grady CDU, like the elderly patients that we get back there, like do you still think when you're looking at the monthly data that they're getting admitted for these types of things, like the anemia and the dehydration, or is it still the cardiac stuff that we kind of thought was the case before?
I think it's probably the people who go under syncope are probably more going for cardiac monitoring, telemonitoring, troponin trending. Occasionally there'll be an echo or a stress test thrown in there. You know, I think it's hard to tease out the near syncope and the you know, hard to tease out those folks and just the dizziness. I think those mainly maybe will go under like a dehydration kind of protocol. You know, the interesting question would be who gets, I don't think a lot of patients get admitted to inpatient services unless there's, you know, some sort of serious cause found.
Okay. So can you guys see me? If you have me on the speaker view, you should be able to see kind of what I have going on. I was going to share a couple of things that I thought were salient this year from about troponin. If you guys know me at all, like I'm a big fan of troponin and not a big fan of stress tests. With all due respect to Dr. Peacock, I gotta dig deeper on the stress view MRI. But I wanted to take a few minutes to go over a couple of things that were salient from the last year. The first one is about something that we all kind of know in our collective gut. And this one is out of Indiana, called troponin testing and coronary syndrome in geriatric patients with nonspecific complaints. And the question is are we over testing? Here they looked at people who were 65 and older with non-specific complaints. They used just their one center, but it's a really big level 1 center, type 1 place, big level 1 trauma place. And they retrospectively looked at triage chief complaints over 6 months in 2017. They adjudicated the terms of non-specific complaint beforehand with 2 doctors, and those sorts of things were like weak and dizzy and like the classic exam requesting, right? So in that 6 months, they found 412 people 65 and older that, and most of them had negative troponin. They didn't publish the troponin ranges in this paper, but they said they used the institutional cutoff ranges for troponin. But out of the 82 who had a positive troponin, 5 of those patients had what they defined as acute coronary syndrome. So, and out of that 5, only 1 patient had further testing where they did a cath, and that patient had subsequently no intervention done. Now, they present this as a way to discuss the risk benefit in admitting these patients, because all of the positive troponin patients were admitted. I took away this point, but also of those 5 patients, if you look at like the individual breakdown, all of them were 78 or older, which kind of says that they probably didn't have enough outcomes to really have a discussion about people who are 65 to 75, which, you know, in my mind, that could be like, it's almost like 2 different kinds of, patients there. Like you can have a very functional 65-year-old ultramarathoner that can be in this situation, which would be very clinically different than somebody who is 78. So that was one thing I took together. But how this relates to OBS is that I think that these non-specific complaints can lead to a lot of OBS unit stays. And this kind of supports the notion that OBS units can take a lot of these elevated troponin patients and address a lot of the diagnoses that these patients ultimately had. Like if you dig into the data, it's things that like we see all the time, like CHF and sepsis and things like that. And these things might become more apparent over the course of their visit. So, you know, in a lot of OBS units, there's like hard cutoffs for troponin. And maybe like we need to consider the OBS unit as not just a place for like this hard cutoff, but like as a place where we can help unearth some of these more common diseases in the elderly, not just ACS.
So I had 2 kind of questions for you when it comes to that. Number one, what are you doing with residents now who are, you know, somebody comes from the nursing home, kind of, you know, weak and dizzy or, you know, delirium kind of thing, and your residents like, oh, I'm going to get a troponin on them. Are you changing your management and saying don't get a troponin if there's no reasonable cause, or you think we still need to know more about that?
I mean, I think you know, in this paper, in the discussion, they did mention that troponin, even in this population, still had a correlation with a higher mortality at like a year and a half, a year, and then further out. So elevated troponin for, I think, any reason is still like a bad thing, right?
Right.
So, I mean, I think finding that and kind of applying it to a specific patient situation is reasonable, but like I think if the resident wants to get the troponin in order to like match weak and dizzy with acute coronary syndrome, is like that's the thing on the differential. I don't think that's as useful as getting it for general mortality risk.
And I know the getting to your comment about, you know, being more comfortable, I guess, with some of these things from an OBS standpoint, I think that's true. And I think as we look to adopt high sensitivity troponin, which is still science fiction at our shops, you know, I think you're going to find a lot of patients with this kind of low level elevated troponin, especially some of these older patients that maybe have some chronic, you know, microvascular ischemia and stuff like that. So, you know, it definitely doesn't mean they all need to go to a cath lab. It just means that they have abnormal troponin, and you need to maybe trend it and come up with protocols, I guess, to do that.
And that kind of brings us to the next thing I was talking about with troponin. I don't know if Frank is still on this call here, but this was a paper out of his shop in Baylor. It was a multi-site sort of thing, but this also isn't directly observation medicine, but I think that whoever directs the observation unit in their shop will ultimately have to be the expert on this issue of high sensitivity troponin, because basically, you know, how it remains science fiction, like for us, is basically no one in the ED is going to want to send, nobody in the ED is going to want to send like any sort of elevated troponin home, right? And then in cardiology is going to be pretty reluctant to admit in cath a lot of these nanogram level troponin elevations with an unremarkable EKG, right? And let me just switch to this grid view. So like by show of thumbs up on your reactions, like how many of you guys have like the ultra sensitive troponins in use like in your shop? Okay, so at Week they got it. Ohio State.
We're getting it next month, so I can't tell you anything about it yet.
Oh yeah. So you know, really like my thumb in the wind on this literature really is about kind of what Mike Ross is saying in the chat here. There's going to be a group of people that like come to the ER that we can most certainly send home, right? Like if they have something below what's called the level of quantification. And then there's a group of people who have like a high level of troponin, which is, we'll just call it the upper limit. And then there's going to be a lot of people who are kind of in the middle that we're going to have to use OBS or risk stratification, like a hard score or EDAX to kind of sort out. And so this paper kind of talks to some of the aspects of that, which I thought were really salient. And there's going to be a number of papers out there that are similar to this, like with a particular assay. So this, again, this paper is put out by Dr. Peacock at Baylor, is a multi-site study of a single assay. These guys looked at data from 2012 and 2013. And they used two low-end cut points, which were 2.3 nanograms per 2.3 nanograms of troponin per liter and 5.6 nanograms to see if there was an ability to rule out an MI that was ultimately adjudicated by a committee. There's a lot going on here, but what they ultimately found was that at these lower limit cutoffs, right, below the level of quantification, and they took two. When you did two measurements, if either of these two values was below the upper reference limit of 17.9 and below the level of quantification, then they were not having an acute MI in the department, right? So let me just, you guys can see my mouse here. So there's a group of people where they did like the 1 and 3 hour measurements. And then they had people who were greater than 17.9 nanograms per liter at any time. Like these people out, needs to be discussed with cardiology most likely. And then there was the group of people who, with the two measurements, was always below 17.9, right? And so again, that's like not above the upper limit cutoff, but below. And if you had a value that was below this upper limit and below this level of quantification, it was the first one was low and the second one was low, the first one was low and the second one was high, or the first one was high and the second one was low. All of those had a high negative predictive value for not having an MI in the department. Two high values, they still were able to find some MIs in this group. So I think with this population at the 2.3 cutoff and also at the 5.6 cutoff, had very high negative predictive values. So I say that to say, you know, in the OBS world, I think like you kind of mentioned, we're gonna have like kind of some cutoffs here. Let me see if I can draw a picture. All right, so there's gonna be a group here where like it's very likely MI, right? I'm drawing on my face, where there's gonna be a cutoff probably specific to your assay. And then there's a group over here that's the level of quantification, which, you know, not to bore you with the stats or whatever, but like that's going to be like pretty much no troponin. And these people probably need to go home, right? If you have like a single value. But then there's this group in here where I think we're going to have to be using risk stratification and whatever tools we have in observation to kind of sort that out. Is that kind of what you took away from this, Dr. Wheatley, more or less?
Yeah, I think at least what we're seeing is, or at least what we're talking about theoretically as we're looking to roll it out, is that, you know, the power of this is folks with no troponin really are, you know, they're not having a cardiac event, at least as a way to bring them into the hospital. And you can probably even lump in your like larger PEs and stuff like that into the, you know, if somebody's truly making no troponin, you know, that is somebody who's low risk. You know, and how that works in, you know, there's a question about using it for the heart scores, you know, in the chat. And Dr. Heastand, who should know a thing or three about the heart score, says that they use it as kind of a supplemental piece of data. You know, what I think is causing a lot of consternation at our shops, and frankly the delay, is I think cardiology is worried that this is going to lead to a lot of work on their end of having to come up with new ways to say why they don't want to cath patients with abnormal troponin. But so I think, like you said, the management of the patients kind of in the middle with those low level elevations of troponin. We're even seeing that with the current assays we've got, where patients with sepsis or heart failure are going to have some low level of troponin, and, you know, they're not having an MI, or at least, you know, a type 1 MI that needs to go to cath lab. So essentially you need protocols to be able to observe them. There was a comment from Robert Bennett that, you know, saying at his shop, they pretty much have no chest pain patients any longer because they use they'll use a delta and admit patients that they're clinically suspicious of, but a lot of them they don't,
right.
You know, they don't necessarily need to keep around any longer. So I think that's, you know, maybe all these folks should be talking about this too.
Yeah, they so in the paper they did discuss a lot of the delta. I didn't talk about it that much here, but yeah, the delta with the high clinical concern, like Dr. Bennett is alluding to, are the types of people that you know, we can either address in the CDU or admit directly. But yeah, this right here, I think, is the CDU population. This right here, you know, the amount of people who are going to be able to get this kind of rule out that's so fast where they need to benefit from OBS, I think it's going to be very small. These are the people that we need to talk about going home right away, right?
Yeah.
So
yeah, and yeah, Leslie and Maria Aney have said that it's happened at their shops too. So decreased chest pain patients.
So so moving on to sickle cell, all right? And so I got the grid view up. Like Dr. Aney presented a sickle cell pathway last year in the research part of the conference. How many of you guys are using a sickle cell pathway for your observation unit by the reactions? It's not a lot. I bet that, you know, and you don't have to, they tried, and Dr. Heisen says they tried and stopped twice. So, you know, I bet it would light up if we asked how many people have been asked to start sickle cell pathway with their OBS unit, which I think was probably almost everybody. It seems like administrators would really, really love if we just kind of took this on. And so this first thing I wanted to show was not necessarily OBS direct. So Dr. Lee says this is one of the top 5 diagnoses. Wow. Okay, so I want to hear from you just in just a second. But but sickle cell is definitely one tough public health disease to address. And occasionally folks make a protocol and they compare it to their local practice, right? So they'll make a pathway and they say, we beat our own admissions by et cetera, et cetera. But really, like what's happening nationally in terms of the delivery model to address pain crises is probably a better benchmark. So HCUP, the healthcare utilization, healthcare costs and utilization project put out a statistical brief last year, September, right around when we had that conference. We didn't have a chance to get into it last year, but they evaluated the national inpatient sample from 2000 to 2016. And it's a huge data set. And it's high fidelity, high quality. And just to give you an idea, you know, it's useful for this population because about 3/4 of the people with sickle cell have a public payer, right? The data set just in 1 year has over 7 million hospital visits, right? So it's a lot of data that they had. And even on top of that, they, for most of these years here, they use weighted numbers for analysis. And, you know, I don't want to go over the whole way they broke down that data, but suffice it to say, like these numbers, even if they have very small changes, are probably going to end up being statistically significant. But there's a couple of things in here that I thought were interesting from the standpoint of OBS unit director who's being approached by administration to start a sickle cell protocol. There's some obvious things in here. Obviously, like most of the visits for sickle cell were for pain crises. And obviously most of the patients are Black. We don't need we don't need a whole study for that. But the length of stay, I can tell you that when we looked at our number locally at Midtown, I think for the other healthcare site too, it was around 5 days. Turns out 5 days is the same nationally. So mean length of stay for patients admitted with the principal diagnosis of sickle cell disease, like overall it's about 5 days. We're talking about kids, like the length of stay is less, but when we have the primary population, like these 18 to 34-year-olds, like that number is 5 and above. So I feel like that's extremely interesting because we talked about several times in this, in yesterday, and I think earlier today we talked about like how do you define like an OBS population where or where you're trying to innovate and come up with something new. One of the things is you do your PEPA report and you look like your 1 day, you look at like your 1 day stays. 5 days is not a 1 day stay. So, you know, even in Dr. Houston's, when he pulled up the PEPA report that they had locally, the sickle cell was not on there. Let me see. Also, the idea that these patients are getting admitted from clinic is probably not true. Over 70% of the admitted, 70% of the sickle cell admissions nationally come from the ED. Interestingly though, to me, is that the AMA discharge rate is almost 4 times higher than the AMA discharge rate of things that aren't sickle cell, right? You know, I see several of you guys mentioning that, you know, you don't have a big population. They also found in this is that, sickle cell clusters around metropolitan areas and certain centers. So that all seems to make sense both in practice. So let me see. What this says to me is that if we are to address these issues, like as an OBS unit director, we have to, one, kind of work against a length of stay that is 5 days, right? We also have to track recidivism, as the recidivism rate is higher than in the general population. We also need to track, be aware of this AMA discharge rate. If you're trying to really provide the highest level of care, you don't want to just bring people to a place and then have them all get pissed off and leave AMA. And I don't think that's what anybody wants to do, but for whatever reason, people are leaving AMA. So, so we have, you know, so really like that's coming up in the chat, it comes up, you know, sickle cell, like Dr. Aney says, sickle cells and OBS requires a lot of coordination with inpatient care and has to have outpatient access. And so really, you know, if you look at like a lot of the quality projects, like when like we walk around through ACEP, a lot of those projects aren't really like the traditional come to the ER, you get like a said workup, and then you journey over to the OBS unit for a set of things. A lot of times there's you know, there might be another clinic involved, there might be a direct admission, and it's like a whole system that is there to address the needs of one patient. Is that what you're seeing as part of the issue also, Dr. Wheatley?
Yeah, I mean, I think at least at Grady, we've got a sickle cell center that at least up until now is going to be run by, or is run by hematology. So a lot of patients with sickle cell disease go straight through that. It's actually a dedicated ED, you know, under EMTALA, et cetera. So it's, you know, right now administrated completely by that division. So I don't know that I have a great understanding for the population that Grady serves. I think you know, we had a few patients at Emory Clifton Road when I worked there that I would see, but I think that, you know, there's obviously a lot of, you know, a lot of social issues that we would need to be able to solve in kind of a multidisciplinary way. It's not just, you know, it is about, I think, being able to provide, you know, pain control and obviously, you know, screening for serious infections and stuff like that. But, you know, you find that, you know, some patients are coming back because they've either weren't able to fill their home pain medicines, or they ran out, or, you know, Atlanta's hot and they get dehydrated. And so, you know, looking into kind of the social determinants of health level of stuff that lead to the recidivism. So, I mean, I think the question as to whether, and I know we're going to get into this in the next paper, but the question is whether an ED OBS unit can provide an issue, you know, can provide treatment for them. You know, I think if it's part of a comprehensive way to kind of see and treat these patients from a hospital administration standpoint, you know, I think that's reasonable to discuss it. But if it's, you know, we don't want to deal with them, you guys deal with them, then I think it's one of these things that's kind of doomed to fail. But you know, and you know, to the detriment, I think, of patient care, you know, because these are the folks, you know, they just need a way to get, you know, I think Avi pointed out, you know, getting actually kind of the patient protocols and stuff like that. If you have a heme service that's really invested and they know the patients well, and they, you know, they have patient level protocols for when they come in crisis, I think that's helpful. I don't know if that answered your question.
Oh yeah, no, I think that's exactly the point. You know, in Dr. Aney presented, you know, the rough outlines of her of the program they have there last year. Hopefully, maybe she can come back or send somebody next year to tell us more about like their 2 or 3 year experience after that first presentation. That would be really exciting. Just throwing that out there.
Dr. Lee's saying they'll have data hopefully to present next year too.
Yeah. So moving on. So the second sickle cell paper, it's actually done just up the road here from folks in Augusta, right? And it's a little misleading, right? Because it says outcomes of an EDOU-based pathway for treatment of uncomplicated vaso-occlusive events, right? This is like the thing you would pick this up and say, hey, you know, this is what I want to do. This is, you know, if the outcomes are good. Really, this is better entitled Their 13-Year Journey to Improve the Care for These Patients. Like, that's really what they did. I think, but you know, God bless them for publishing it, because like, I think it sends home the point that like we've all been kind of saying here in the chat. So they had a 13-year effort. They started trying to rapidly identify patients with uncomplicated crises and place them in the observation setting. And what they did was an iterative process, a bunch of interventions, including like giving the patients a PCA. They started multidisciplinary meetings. They even gave up management of the EDOU to the hospitalist service, which you know, kind of is it's a little buried in there, but like they gave up. So the hospitalists run their observation unit, and so you know they exclude like the things that you would expect here: acute chest, aplastic syndrome, and they get it down to you know, just the basics for the vaso-occlusive crisis. And then they place patients in the CDU and they try to get that done as soon as possible. So, so they go over a lot of the things that they tried, but you know they did. They started in 2005. They started their pathway after some work in 2006. Back in 2008, they started bypassing the ED and using PCA only medications. They further started working on individual dosing like in 2010, and then they gave up management of the OBS unit in 2013. And so the blue line here is admission for all of the things at their shop. So this, and then the orange line is admissions for the cohort that they were talking about. And so over time, you know, you can see that they improved their admission rate. They also improved like their 30-day return visits. And they improved their 3-day recidivism rate, which, you know, a lot of times isn't captured, but, you know, hopefully like with this HCUP data, we can start talking to folks about the AMA rate as being part of like the standard data set. And so they had improvements. Ultimately, you know, their length of stay for these patients at the conclusion of when they were at their most recent iteration, which was like 2016 to 2018, they were able to get the length of stay down to about 18 hours. But really, you know, this is less about one single intervention and more about quality and implementation science, right? So like what they did is they had meetings and then they fixed the process. They tried to add in resources. And, you know, my takeaway from this article is that really trying to solve a complex public health issue like this that has a lot of layers of social determinants of health that requires like coordinated outpatient management and really like centers around a disease that, you know, is almost defined by pain, right? Which has a lot of its own social factors, is a very difficult thing and requires something like a coordinated response.
Yeah, I'm interested to hear. It sounds like the Jefferson group has some interesting data and interesting experiences with it too. So, I mean, I think this is something where we're going to obviously have to continue the conversation, and I'm sure there's going to be more best practices that will come out of it. And we'll get the link to that paper posted in the chat.
Okay, I'll take care of that. Go ahead, sir.
Looks like Dr. Pena took care of it. Wonderful. All right, I think we're going to share kind of our last article here. And we're going to take kind of a hard left into the kind of deep nerd section, although I have to confess I'm not necessarily as much of a Star Trek nerd as others, but I'll try to do it justice. So Margarita talked in her COPD talk about the Borg score. And so I think this is, you know, one of a long line of either local QI projects, you know, us all trying and striving to find the right fit for our COPD patients to see who are the best ones to select to come to the OBS unit, where we know they're going to go home and they're going to kind of fit that 80% discharge in 15 to 18 hours kind of rubric. I think all of us realize that COPD is a very different disease than asthma, and a lot of patients look clinically well, but it just takes them a long time to get back to their baseline where they feel comfortable going. And we've seen locally that most of our like respiratory arrests or codes in our unit are COPD patients, and they're the ones that are looking good, sitting in bed, off oxygen, and then they get up to use their bathroom, and when they come back, that everything just kind of kicks up again, and they wind up on BiPAP or whatnot. Much different than the asthmatics or the heart failure patients, that once they get on treatment, they tend to have a fairly predictable course. So this study here is a single center study that was done out of Cincinnati, I believe. And it's actually a two-phase study where they did a retrospective arm to derive the score, and then they did a prospective arm where, as was mentioned, they did Q4 hour measurements of the Borg score and the dyspnea assessment score. And what they were looking at in this was safe discharge from the OBS unit, which they defined as no return visits within 7 days. And so what they found in their phase 1 was they actually had a pretty low safe discharge percentage. Only 48% of their patients had safe discharge. They had a 6.4% revisit rate and a 45.6 conversion rate to inpatient. So, I mean, I'd say that's probably fairly common to what a lot of us see with our COPD patients. And this was 171 patients. They didn't find any correlates with safe discharge. None of their clinical variables really correlated with safe discharge. Their phase 2 was a smaller group. It was only 38 patients, and they found 52.6% were able to be safely discharged from the OBS unit. They did find that their predisposition Borg score was lower in patients that were safely discharged from those that weren't. It was 2.75 versus 5.28. And if you can look kind of down here, 2 is easy, quote unquote, easy breathing versus 5, which is hard breathing. And so, some of this is difficult because it's a subjective score. So, you're asking people to kind of rate symptoms based on how people look or feel. So, in the end, they were able to find some kind of small signal that said, the Borg score could be predictive, but there wasn't any large signal about, these patients are good for OBS versus these aren't. So I think we're still kind of searching for that, if I can mix my sci-fi or fantasy metaphors, it's more like searching for the holy grail of who we can discharge from, or who can come to the OBS unit and be discharged safely. I don't know, what were your thoughts on this one?
It's similar to what yours are. I think, the one thing I did like about this was a lot of the elements of the Borg score. I think that's something that, I haven't been using in my practice clinically to evaluate these patients in the observation unit. I think like this could be totally additive to kind of like your routine rounding in the OBS unit, like particularly like if there's, you have the type of OBS unit where you don't have like a dedicated group, like a second group, like in, you have providers that don't always round in the OBS unit and they want to know what kind of things are necessary to discharge people. I think, the Borg score is easy enough to understand to where like you can use that as part of your clinical decision making.
Well, the interesting thing, and I think I probably need to look into this a little more and see if there's been tests of this versus, unstructured clinical judgment, because I think where we found with the faint score for syncope that it actually performed better than unstructured clinical judgment. You know, and this one here, there was at least more signal for the Borg score than there was for the dyspnea assessment score. And the question would just be, you know, I think at least what we do in our unit is, you know, you round on the patient, you ask them how they're feeling, you do kind of an assessment of how comfortable they look, and then, you know, we will road test all of them. And I know there was a question in the chat during Margarita's talk about, you know, any data on mobile, you know, pulse ox. You know, some patients I think will go ahead and do mobile pulse ox for if they're, you know, maybe, you know, mid to low 90s on room air at rest. You know, you want to make sure they're not going to the 80s when they're exerting themselves. But I think people with, you know, 100%, 99% oxygen saturation at rest, we don't necessarily do that. But you want to make sure at least they're going to, you know, our CDU is a square, so we have them walk around the square. You know, and if they can do that and feel comfortable, and sometimes I'll ask them, do you feel like you can go home, or do you think you're going to need to come right back if we let you go home? And I find that that's almost the most predictive, at least of what the, you know, the patient's perception of it. So, you know, the question is that more or less sensitive than, than this score?
Yeah, no, that's a good point. That's a good point. So does that wrap it up, Matt?
I think that's it. There's just reading through the chat stuff.
So echo use, back to the syncope issue. You know, it's very hard to educate like a large group of providers on what to and to not order in going to the CDU. Like we have, correct me if I'm wrong, Matt, like 60 or so grade E specific providers. And like a lot of them are gonna order echoes because they're just used to ordering the echo. You know, I think it's outside of like the indication of like, you know, abnormal EKG or a murmur or something like that. Like there's obviously not reason to do it, but out of things like out of resource utilizations that are harmful, I wouldn't put echo very far at the top. Like, you know, the stress tests that we do involve like a lot of radiation, but nobody needs that. A CAT scan that we do of somebody's neck for whatever reason, nobody really needs that. But the echoes, you know, they happen like when I'm rounding back there. I try to cancel a lot of them, and we try to educate the residents. But you know, we don't have anything specific for not ordering those, and other than providing guidance.
I think echo falls under one of those rubrics that I think we in emergency medicine are guilty of, and maybe medicine in general is, you know, it's better to do a test than to not do a test. And you feel like, you know, putting somebody back there just to watch them on telemetry monitoring, you know, is not enough of a hard outcome. You know, it's like, well, once their echo's back, then I can discharge them. And if it's negative, I can discharge them. And, you know, I think there's data to kind of show the opposite, that it's really not needed. And I think it's just more of a, you know, discipline thing for us as physicians or as providers to, you know, say we don't necessarily need that. You know, we're doing a great job in kind of dismantling the need to admit everybody with syncope and do a multi-million-dollar workup. You know, we haven't necessarily placed the then what in there. You know, I think some of these centers that are able to do, you know, do kind of some sort of, you know, whether it's a loop recorder or something like that, or get some sort of home monitoring system for heart rhythms, you know, that's probably the best thing. That's hard to set up. There was a question of whether we do peak expiratory flow for COPD patients. At Grady, we don't. We used to have RTs that were kind of more stationed in the ED and would do that for patients. I think, you know, at least for our folks, you know, they don't use their peak flow at home to know when they need to do their treatments. I mean, that's what it's really for. It's that kind of red, yellow, green for how symptomatic you are. And most of our patients will just either give themselves a treatment when they feel they need it, or they'll come in if that's not working or they're out. So we used to use peak flow a little bit, but it's kind of resource intensive.
Okay. Well, we're going to switch gears a little bit here to our poster type presentation. I guess like we're not in person, but even if we were in person, we wouldn't be using paper. But the Research and Innovations Forum. And I just wanted to say a couple of things. I don't know if I'm going to get a chance to talk at the end. I'd like to say I really appreciate Dr. Pena, who was really like the workhorse, like, cause she lives in Michigan, in helping us put this together. Last year we had a lot of research presentations. This year a little bit less, but this year is a very different year. I appreciate everybody's patience, like with me, and I appreciate everybody's patience and kindness towards each other. Because like this is definitely a more difficult year to get projects off the ground than any other. But I say that to say that I'm almost sure that this won't be the last MSEP Ops conference. I don't want to jinx it, but for next year, feel free to tell your story about COVID, because like this sort of thing is like lightning in a bottle. And even though like there's a lot of experts that think that this is like every pandemic is going to be different, I think that the way OBS units can adjust in the future is something we can share and experience in the future. So next year, like the posters don't have to be super complicated. You don't have to have a ton of outcome data, but like having a place where you can share like, this is what we did for our OBS unit. This is how we flexed to use the beds. Whether or not we did testing in the unit, not in the unit. There's probably going to be another pandemic at some point in many of our lifetimes. So like this experience is going to be interesting, even outside of the context of coronavirus. So we have 3 folks that were going to present. And 2 of them were about benchmarking, and one is about the medication-assisted opioid therapy program that we kind of run out of the observation unit at Grady. So first, we're going to have one of our residents who helped us out with this. Dr. Mayberry, are you able to share your screen?
Yep, give me 1 second. Hello, everybody.
Dr. Mayberry is one of our chief residents. He's a PGY3. And fun fact about him, he played guard in high school, pulling guard on the football team. So, so don't let looks fool you. He will come around and clean your clock on a shift. So.
Probably not. Give me 1 second. Sorry about that. My Zoom was malfunctioning a little bit. There we go. All right. Okay. All right. Can everybody see my screen okay?
Looks good.
Okay, perfect. All right, so I'm just going to take a couple minutes. Again, I'm Donnie Mayberry. I'm one of our PGY3s. It's really nice to virtually meet all of you. I just want to take a couple minutes to present this first poster presentation to everyone. And as you can see here on the screen, it's the Emergency Department Benchmarking Alliance Survey, the Anatomy and Physiology of an Observation Unit. This study, first and foremost, I have no relevant financial disclosures. That would be wonderful, though. Just to kind of talk a little bit about the background of this study and sort of why it was very important. Caring for patients under observation is a very important part of medicine, and it's also a growing part of medicine, or at least presumably so. A large number of centers across the country are developing dedicated observation units to cohort people in trying to prevent inpatient admissions. And there's data to show that type 1 observation units are good for patient outcomes, that they reduce hospital stays, they reduce costs, and they also just overall decrease admission rates, which is something that all of us are very interested in trying to continue improving. Back in 2003, a survey went around the country, and the net result of that was that approximately 1/3 of U.S. hospitals had observation units, and that was the statistic that was quoted and has continued to be quoted since then. But presumably there are more places now, and that people should hopefully be doing these things more often and better. And so the purpose of this study was to create a new survey to try and get more information about how many observation units there are, where they are, and how they're being run, and sort of what their metrics are. And so this study is trying to answer exactly that question. So the actual design of the paper itself. So the survey was sent out. First, it was created and using embedded SurveyMonkey link. It was sent out by email to over 1,700 institutions through the Emergency Department Benchmarking Alliance, the EDBA, and then also through ACEP, specifically the Observation Services section. The responses were collected. They were all de-identified and then entered into an Excel sheet for further analysis, and all of that data was securely protected by the EDBA. Overall, starting to jump into the results section, about 90 sites responded to the survey. Of those, 7 were incomplete. So approximately 83 full responses from 28 states and the District of Columbia. So it's a low response rate, but still kind of covering a broad area of the country, and did provide some very interesting information. To go through some of the results of this study. So the units themselves, after reviewing all of the data, the majority of our observation units around the country are closed units. They roughly were, the median number of beds was 12, although the span itself was 10 to 18. Overall, the vast majority, so all but 7 places, used protocols. So that's only 8% not using protocolized patient care, which is, again, an important metric for quality. Looking through at some of the actual numbers through these observation units, so the median annual volume was 4,015 patients, with a range anywhere from 2,600 to over almost 5,500 at the highest volume. Again, the median number of beds for these observation units was 12, and the median length of stay was about approximately 20 hours, with a range of 17 to 23. The median occupancy was 0.7, and overall the average conversion to inpatient status was approximately 16%. Looking at the actual protocols that were being used, somewhat as expected, currently the most commonly used protocol in the observation units across this survey was chest pain, but also very commonly used was abdominal pain, syncope, TIA, and then asthma and COPD. One of the other things that we were very interested in is who's actually doing the admitting and who's actually doing the staffing of these observation units, specifically the ED observation units. Around the country, so 61 of the 90 sites, or 67%, where the emergency medicine was who was doing the admitting to the observation unit. About 5.5% of the hospitals was the admission to the CDU was done through the hospitalist or through an internal medicine trained physician. One site actually had cardiology doing their admission, so you can imagine that was predominantly a chest pain site. And then lastly, and interestingly, about 15 places, or 16%, had open units where anyone could admit a patient to their CDU. The vast majority of these sites used advanced practice providers, so 76.7%, or 69 of the 90 units, were using APPs in some capacity. The majority of hospitals, or of these observation units, did have physician oversight. Approximately 54% of the hospitals, it was an emergency physician who was also working elsewhere in the ED who was responsible for covering the CDU from a physician standpoint. Approximately 20% of these observation units had a dedicated physician, and then there was actually one hospital where there was no physician oversight, and it was run solely by advanced practice providers. From a nursing standpoint, the most common patient care ratio was 1 to 5, although there were as low as 1 to 2 and as high as 1 to 8. So there was a little bit of variability there, but again, about half meeting the expectation. That's really it as far as the data is concerned. To run through the conclusions of this study, The typical observation unit that came out as a result of this study, which is really what we were trying to capture, was a closed unit that was admitted to by the emergency department and emergency medicine physicians. It was protocol driven. And it was taking care of roughly 8 to 9 patients per day who were staying approximately 20 hours, and only about 16% of them were being converted to inpatient stays. For the most part, these results were consistent with the known best practice guidelines for observation medicine. And looking over some of the areas for improvement were going to be decreasing the net length of stay for our patients, and then also trying to increase the overall census of patients with the occupancy of 0.7 being slightly lower than expected. The limitations to this study, it is important to note that this was a survey study, and so the data that we generated is only as good as the responses that we got, and there are certainly external biases that we're unaware of as far as like who responded and why they responded and were there any limitations. We postulate that we might have gotten a different set of responses had we included hospital administrators or internal medicine physicians as well, which would have helped broaden our scope. And we did have a somewhat reduced response rate at only 90. But again, many of the facilities that were included in this do not have a dedicated ED observation unit. And finally, moving forward, we would suspect that given the importance of observation medicine, that there would be a significant benefit both to patients and providers if we could have a national registry looking at observation stays as well as observation visits and their outcomes. And then lastly, as data comes out on chest pain and sort of the impact of ED observation for chest pain and the lack of efficacy of stress tests and certain patients not needing catheterization, potentially having a decrease in the number of chest pain visits, and looking for new patients and new protocols to safely monitor patients in the observation units as the number of chest pain stays decreases moving forward. And that's it. Thank you, everybody.
Yeah, one of the things I was surprised about in this study, even like, I mean, because we worked, I forget, we've been working on trying to get this study out for at least 4 or 5 years now, and you know, I thought that chest pain was like on the decrease, but I'm still very surprised that that it's still there at the top. But you know, a lot of the things that are in here are kind of expected, like when, and Mike can tell me if I'm wrong, but like a couple of papers, I think on the prep and in the toolkit, like we talk about bed utilization as like, you know, somewhere around 0.9 patients per bed per day, right? And that's borne out in the data, which is pretty interesting. You know, we've been talking about trying to find things to do other than chest pain, and TIA is up there as one of the more common pathways. So, you know, amongst a lot of other things that we kind of knew, I thought those findings were in particular useful going forward in our discussions about observation units. So next we have, let me just look in the chat here. So next here we have Dr. Chandra, who I think you guys have all met before, and he is going to discuss with us some similar data, except out of the Kaiser system in California. So please, sir, proceed.
All right, well, I was trying to share my screen. I don't know if you were able to see it.
Yeah, we got it.
Your screen now, yeah, you're good.
You got it?
Mm-hmm.
All right. All right, so yeah, you know, a lot of these, first of all, Anwar, it's, I am amazed at how many EMIM folks we have on here. In 25 years ago, when I first was applying to residency, there weren't that many. So it's awesome to see EMIM finding a role and niche in OBS. But with a lot of these, so moving on to this research data, it stems from just questions, and as directors, we're trying to understand what's happening with our units. With Kaiser, we have, you know, 2, 3, 4 million folks who are part of the Kaiser system that extend in California, along the West Coast, Hawaii, and along the Mid-Atlantic. And so as we were, as I was trying to expand OBS in Kaiser and in California, and got tuned into a group that was working across all the different regions, we started asking questions, and this is some of our information that we gleaned, and hopefully it, you know, I'm be really curious if once I present this, if the rest of the team that's on this meeting sees if their numbers kind of match up to what we found, and you know, this can maybe put some teeth into benchmarks going forward. So I worked with Adam Sharp, who is an up and coming, amazing emergency physician researcher. He is going to knock everybody's socks off once you get to know him and look at some of his stuff. He's phenomenal. And Rebecca was doing all the data analysis in the system at Kaiser with Epic, which is an incredible task. So, you know, managed care, the contract is, hey, you give us your dues to be part of the Kaiser system, and we're going to take care of you, and a lot of your services are going to be covered and without extra out-of-pocket stuff in general, just to sum it up. And as I mentioned, there's about 35 medical centers when I include Northern Cal, Southern Cal, and then Hawaii and the Northwest region. And some of the areas, just because of things we'll get into, I had to narrow down who we were working with. Now, this is a little bit of a difficult work because, you know, OBS is new to this Kaiser. And so everybody was kind of doing their own thing. So we really had to define and narrow down the people we're going to look at and the patients we were going to look at that could easily be extracted and consistent to try to answer the questions we wanted. And our questions were, hey, let's look at our 7-day return rates, because administrators are always asking, what's your 7-day admit rate? Is it too high? Should you be doing better? You know, and then the next is just understanding length of stays for some top conditions as well. So this is how we finally refined our definition, which took a lot of work, believe it or not. It wasn't as simple as I thought it was going to be. People had to be anywhere from 6 to 48 hours length of stay. And it's from the time they were actually roomed in the ED. So in case there was wait times in the lobby, we did not want to include that. The primary diagnosis had to be one of the observation diagnoses that we identified. And, you know, we are obviously excluded inpatient status. And so we came up with patients with an observation amenable diagnosis in either a final patient class of observation, or you could actually change in our EPIC system indication of observation. It was called transitional patient care, I believe, in Southern Cal, and then CDA status, or clinical diagnostic area status, in Northern California. And these were the diagnoses that we narrowed it down to looking into. And the order that you see here from 1 to 13 is also the frequency of the diagnoses that were observed. So the most common was chest pain, syncope, UTI, vomiting, and TIA. And I think Donnie mentioned some of the most common diagnoses, and it kind of fits along that pathway. Now, just to show you about Kaiser, this is 2013, 2014, a little bit of 2015, so 8 quarters of data in ED visits. So we're looking at 2 million plus ED visits when you combine the 4 regions I specifically alluded to here in this area. So that's the population we were working with initially. And so this is our first data that we found. And so when we defined our OBS patients and we extracted the data and looked at their 7-day return rates, what we saw was a really great symmetry in the Northern California and Southern California, and a lot of divergence in the Hawaii and Northwest. And that's probably because they had way fewer patients than the Northern Cal, Southern Cal, and fewer medical centers. So between Hawaii and Northwest, we're looking at 3 medical centers versus 30 plus medical centers combined. And so, as you can see, it ranges, you know, in general between 6 and 9% over this 8-quarter period. And then we actually looked at a 12-month period by each medical center, because there's variety. You know, your patient mix is different, your practices are different, and so it's not always one size fits all. And as you look at this over these multiple sites, you're really going between 5 and 10%, and the median being in that 7 to 8%. So I think for us, we came away with saying, you know, boy, if we're averaging in that 7 to 8%, you're probably, you know, doing pretty well as best as we can. Now, when we, little background on this, these centers do not have an official observation medicine program, meaning they do not have protocols they're following. These are all run by Gestalt, mostly by ED, but some by inpatient services there. So there's a huge variety in practice here. And it's fairly unscripted. There was at this time really only about 2, maybe 3 major centers that had ED run formal observation programs. That was my place, San Diego, Kaiser, and I think one other in Northern California that really had a dedicated formal program that was doing this. And so what I'm sharing and what Donnie mentioned was in his talk, that there's a lot of virtual observation being practiced. And so I think this reflects those practices that is happening in our communities across this country that are practicing observation. And I think we need to, the better we understand what is going on in places across our different hospitals, I think is how we can help them and understand and learn from each other. So when if you looked at the graph and just narrowed down the Southern California data, really the return rates, as I mentioned, was between 7 and 8% for these folks. All right, so the next step was looking at the benchmarks of length of stays for our patients. And we used the top 5 diagnoses, really tried to keep it a little simple. So again, the same definitions as before. And this is kind of each column is a different diagnosis. The top part is the Northern California, the bottom part is Southern California. And you can see, for example, in chest pain, the 25,000 patients, I think this is probably one of the largest attempts at consecutive patients that we extracted, trying to obtain mean length of stay. Now, there's a little bit of variability there, especially in the median times. And I think that's because of practices on how many patients got functional studies, how many patients were discharged after troponin, and what time of day and night and so on that are really impacted creative variability. But in Syncope, as was mentioned before, I think we're coming up at about 20 hours if you combine both Northern California, Southern California, and we're looking at about 7,500 patients almost there. And the admit rate between 8 and 12% for these folks. I think we started finally getting a little grasp of what kind of numbers should we be expecting. Again, this is very unstructured in general care, that's prolonged care in a ED/virtual OBS type of setting. Pilo/UTI is another one, about 15 hours, nausea, vomiting, dehydration, about 14 hours, and then TIA in that 20 to 24 hours mark. And you know, admit rates are different, and of course is based on what type of patient selections you have with what symptoms there. And this is just another look at this graphically when we combine just in Northern California, Southern California, how close they are to each other there. And so in summarizing our findings, you know, we're looking at everywhere from 25,000 patients for chest pain to about almost 3,000 patients for TIA, 5,000 for Pilo, 7,500 for Syncope. And we were able to define in the Northern California and Southern California region, some benchmarks in an unstructured format. Now, what would happen in a structured format? That's to be seen. Hopefully some of these length of stays come down. Some of these admit rates potentially come down because you have better patient identification there, or they go up. You know, it may go either way, but this is what we found in there. And so, you know, with Kaiser, with a closed system, with it all being linked with Health Connect and Epic, you have access to data, but because you have so many different regions, that data that you can access is limited at times. And so that's part of the limitations we had. But I think this in general provided us some understanding of what our expectations and benchmarks, at least within our system. And I'd be very interested in finding out if other folks at their other individual sites are seeing numbers that are very similar to this.
Can you take questions?
Yes, please.
Yes.
Avi, this is great stuff, Sharon Mace. Congratulations. My question, it's something we all kind of suspected, TIAs and Syncope are going to have a longer length of stay than chest pain. One of my questions, though, is I'm trying to recall percent admission rates, and it seems to me that yours are much lower than what I've seen for from other studies. And I wondered if that might be unique to Kaiser, because you really do. Kaiser has a very well managed, they have follow-up on all their patients and so on. So do you see your admission rates as being lower than many other studies?
Yeah, it's a great question, Sharon. Thank you. And so some things yes, something no. And what I mean by that is we have a great, you know, because we have such a big variability of practices, in other words, meaning some hospitals are more suburban, some are more inner city. Some folks have predominantly insured patients. Other centers have 20, 30, 40% non-Kaiser insured patients. So we have a huge variability, and it doesn't matter what payer mix you are when we observe you. You can have no insurance, you can have Blue Cross, you can have Kaiser. It doesn't matter, you get the same care for everybody. And so, yes, there is, I think, a influence of a managed care system. But I guess what I would say is I think all of our understandings of the people who require admission, let's say for TIA, is fairly standard, and people who can go home. So if you have an abnormal MRI with, let's say, a small lacunar infarct and everything else is fine, they can probably still go home if they have TIA, versus if someone has, you know, motor deficits that they really need, or speech deficit, they need to be admitted in general. That's not something I can easily manage or send home and manage from home, even in Kaiser. So yes, we have some decreased rates. It may be just practice style. I don't have the data at that level to be able to answer, because there's such variability. But I think what it could be, or this could maybe be, you know, to be a devil's advocate, the real truths in the universe, and we need to understand why other rates are higher.
Thanks for presenting that. I mean, I think that's all very compelling. I have a question. Like, so I guess if we were to look at all of the chest pain stuff, the 16 hours for the length of the stay is is really good. And I think TIA, like, if you pull that out nationally, that's 22 to 24 hours is also really good. With your like thumb in the air, like what do you see the biggest gains in like these hospitals that kind of have like type 3 and 4 observation settings? Where do you see like the gains? Do you see them in more of like a bed utilization upstairs if they were to make an OBS unit? Or do you still think that there's there's some room there to improve the length of stay?
Yeah, so you're asking, Anwar, if I understand, if we go from a virtual unit to a dedicated unit, how could we see changes or improvements?
Yeah, what would you expect based on like what you guys have now?
Yeah, I think the key is you have to have an ED run unit right now. I think I think if we had an ED run unit, in our experience that we had at my institution and in some of the other institutions that I helped start with an ED run unit, your admission rates go down. And in a managed care system, you know, when you're getting a finite pot of money, it's not a DRG run, it's not a procedure reimbursement per se. Efficiency is everything. And patient satisfaction is everything, because we want these members to stay with us and stay with our insurance. And so we have found they're super happy. The improvement from being virtual to a dedicated unit, their satisfaction scores, ours went up by about 10% in our numbers. And then our admission rates went down. Our ED throughput improved. So our change in acute care beds, you know, improved dramatically. Right now with virtual, you're taking up an ED bed, right? And so your capability of taking in new ED patients, your outflow is impacted there. So by having that, you're able to then look at ambulance diversions and other things like that, that potentially your NEDOC scores, all of the things like that that are impacted if you have a dedicated unit upstairs. But it has to be running the ED. And for another day, another time, we'll talk about my experiments in trying to help the internists, inpatients develop their OBS units and the barriers we came up with and practice strategies that we learned that could actually help them do that.
Any other questions before we move on to our big finish? Okay. So next we have Dr. Nicole Lang, who is a PGY3 resident in Emory, and she has had an interest in addiction medicine for more than a year now, and is really taking the lead with our talks group and working on a handful of projects. And she is going to talk some about our MAOT pathway at Grady. Dr. Lang.
How can I get this off?
Hi, everyone. Thank you so much for having me. It's nice to virtually meet all of you. Just getting this set up. Great. Are you able to see my screen?
Yes, we can see your screen.
Perfect. So I'm going to spend a few minutes today talking about research that we're currently doing at Emory to evaluate effects that our observation unit is having on decreasing stigma and disparities in opioid use disorder among our patient population. This research was conducted out of the emergency department in concert with the observation medicine unit. A lot of multidisciplinary work has gone into this with our talks department, as well as other members of our addiction team at Emory. So to start off with some background, as I'm sure all of you are aware, opioid use disorder is and remains an enormous problem in the United States, with morbidity and mortality associated with opioid use disorder and overdose continuing to rise. Medically assisted treatment with methadone, Suboxone has really become the standard of care in treating these disorders. And over the last several years, there has been increasing rates of emergency department initiation of medically assisted therapy, which has shown some exciting outcomes in terms of treatment of these patients. However, in our research into medically assisted therapy, there are concerningly some patterns that that women and people of color, particularly Black patients and Latino patients, are less likely to receive outpatient opioid use therapy use disorder treatment. They're less likely to be prescribed Suboxone from the emergency department, less likely to follow up with care, and then less likely to complete their care that was initiated in the emergency department. This has a lot of very far-reaching implications, particularly as relate to female and minority patients. With regards to female patients, they unfortunately have lower rates of referral to medically assisted therapy, are less likely to complete their care, which can have some pretty far-reaching implications for not only the patient, but also for the healthcare system in general. female patients are more likely to represent within a shorter time period. Interestingly, they're also less likely to receive naloxone in the setting of acute opioid ingestion. Minority patients are also less likely to receive referral for medication-assisted treatment, and then are less likely to have 30-day compliance with their treatment. So with this in mind, we were interested in investigating how the concept of a warm handoff and utilizing our observation units could affect or impact these disparities that have been observed in the initiation of medication-assisted treatment in emergency departments. For those of you who aren't familiar with it, the idea of a warm handoff was really something that was developed by our colleagues in behavioral health and primary care. And it's the idea that when one physician introduces a physician from another team or another framework of care, the patient is more likely to follow through with the protocol or the treatment that's being initiated, in this case, medically assisted treatment for opioid use disorder. So the goals of this study was to, first of all, just determine our rate of follow-up to outpatient medically assisted therapy after initiating Suboxone in the observation unit. And then we were evaluating furthermore any disparities or discrepancies we saw in follow-up based on race or gender for those patients who did have MAT initiated in the observation unit. So inclusion criteria for this study was any patient presenting with opioid use disorder, whether it was an acute ingestion, whether they just presented to the emergency department with a chief complaint of, I want to start Suboxone, and assuming they were highly motivated for Suboxone initiation, and then that they didn't have another medical comorbidity that suggested that they needed to be admitted as an inpatient. Suicidal ideation was an exclusion criteria. They had to have stable vital signs, mental status, and then we had to obtain a toxicology consult in the emergency department with a plan for initiating Suboxone. Toxicology is the lead division in our department for our outpatient medically assisted therapy program. So they generally run the majority of our addiction treatment at Emory. Exclusion criteria, as we already mentioned, any sort of suicidal ideation, any other indication for admission either to medicine or indication for inpatient psychiatric admission, concomitant use of benzos or ethanol. And then, as we mentioned before, it was to validate the concept of the warm handoff, toxicology had to be consulted in the emergency department. So what can we do for patients with opioid use disorder in the CDU? One of the main things we can do is track the progression of their withdrawal using the clinical opioid withdrawal scale, the COW score, for those of you who aren't familiar. There is decided benefit to delaying the initiation of Suboxone until the onset of objectively evidenced signs of withdrawal, so as not to precipitate withdrawal in a patient who hasn't already crossed that threshold. They could also receive any necessary lab or drug screening, and then most importantly, and I think this goes a long way in establishing that warm handoff model, they could receive symptomatic treatment during the initial phases of their withdrawal. So at this point, in the observation unit, they would have an opportunity to meet with our addiction specialists, our toxicologists, to determine if they were appropriate for discharge with close follow-up, usually within several days, to the medically assisted treatment outpatient clinic, or if there were any signs of severe symptoms development, or any signs or worries for co-ingestions, they could be admitted from that branch point as well. So the methodology of the study was a retrospective chart review conducted from January of 2018 to October of 2019. We had 101 uses of the medically assisted treatment protocol in the observation unit at that time. We conducted a chart review. We excluded any duplicate cases or any cases that had missing outcome data to result in 88 unique patient encounters that were reviewed for data. So in terms of our aim to investigate racial disparities in follow-up to medically assisted treatment, you can see that on the left, the breakdown by race of our subjects from the ED to the CDU and then the CDU to clinic. What was reassuring in this case was that there was not a significant disparity or significant difference in the racial breakdown of patients who were referred to CDU versus those who ultimately presented to the outpatient clinic for follow-up. In light of the pretty robust set of research that suggests that people of color are less likely to follow up as outpatients to receive medically assisted treatment, it was reassuring to see that we were not seeing those same patterns demonstrated when we were using this protocol. Fortunately, the same pattern held for our female patients as well. When we looked at the data in terms of gender, about a third of the patients who were referred to the CDU for the Suboxone initiation were women. It's consistent with a general trend towards a male predominance in opioid use disorder. And then about, again, a third of patients presenting to clinic who had been CDU referrals were, again, women. So the rate of retention of both women and people of color was very reassuring across our study. So although the study was small at this point, it does suggest some promising data that standardizing an observation use pathway can help to lessen some of the discrepancies we see in referral to medically assisted treatment for both women and people of color. Obviously, further research is going to be needed to determine how this holds in different populations, different emergency departments, and then to further characterize the role of observation units in addressing the opioid epidemic. I'm happy to take any questions we might have at this time or talk further about our data.
Great job on that presentation. For me personally, like this is one of the reasons why I like OBS so much. And, I think, when we put practices in place that kind of that can make people neutral arbiters, I think a lot of disparities go away, right? So, the thing that I really liked about this was that, we looked at basically the OBS unit as a way to standardize who gets put on the treatment and gets the warm handoff with a group of physicians who are the toxicologists who really didn't have a stake in the discussion outside of the just following up in clinic, right? So, the next thing that's going to be hard for us, harder for us to figure out is if that same distribution of population looks the same like when they walk in the door, right? Like all the overdoses that match up to that percentage, and does that same percentage end up in the CDU, and does that same percentage follow up? So, but great job, and we'll take any questions here.
Anwar, just kind of chatting with you guys offline, but it seems like you guys have a tox fellowship, and it's kind of that academic group that sees the patients on consult. If you don't have that, like in my shop, we don't have tox fellows or anything like that. How do you envision doing this then without them?
I think it would be to partner with whatever your kind of local organization is that would be seeing them, because for us, it's the toxicologists that run the medication assisted treatment clinic.
Some places it's addiction psychiatry.
Yeah. And so it may not be necessarily an in-person warm handoff, but it may be a, over the phone handoff, similar to, if you're referring somebody to a neurology clinic or something like that, the neurologist may not necessarily come in and see the patient, but you will give them follow-up information. Obviously you have to take your local population into consideration with that, because, obviously these patients as a facet of their disease, sometimes it's, you know, difficult for them to make follow-up appointments, you know, and depending on how easy that is versus, you know, going out into the street and getting more opiates, you know. So I think one of the features that we really felt was good about this was that the patients actually get to meet the folks who are going to be kind of in the clinic with them, but it obviously will look different at places where it's, you're referring to more of an outpatient thing.
Thanks, Matt.
The other thing I think we noticed, and I think one of the features that our toxicologists were able to do, is that sometimes patients come in and they're not necessarily in enough withdrawal to start the Suboxone. And so, you know, if you gave it to them right then, you could actually precipitate the withdrawal. So, I mean, that's, I think, other than the warm handoff bit, that's the part of actual like toxicologic knowledge that they are actually bringing to bear on the patients.
The questions was, do we require a positive drug screen for CDU admission to the for OUD? I don't think so. They end up getting it though, so it's going to be hard to separate that. Like they usually end up getting it one way or the other. Like the you know, the drug screens really get drawn because in our system, like in order for anybody to be referred for like a outpatient treatment, then you have to have a UDS to like look for co-ingestants, and that's like the same for like alcohol, cocaine, or whatever. So it's very hard to separate that out.
And Dr. Lang, what's been your experience? I feel like every time we bring up the drug screen to our toxicologists, they kind of scoff at the whole concept of it. So what have they talked to you about on rotations and whatnot?
Yeah, so it's certainly not necessary. One of the main benefits, I think, of having a little extra time in the observation unit is kind of trending that COW score over time. And generally speaking, we won't administer Suboxone to people who don't have physical evidence of withdrawal. So I think that that plays into this decision more than just what you would see on the drug screen, which I think we all know is not, you know, one of the most reliable tests that we have in our arsenal.
Right. So yeah, so people they can have a positive drug screen and then have no signs of withdrawal and not get put on, like not be part of the MAOT pathway. So that can happen too. That's a good question though.
Mm-hmm. Yeah, I know that's a lot of outpatient treatment places are going to require this, but I think for the most part, we base it on our clinical findings. And, you know, most patients, it's, you know, will come in requesting this kind of resource. You know, again, the person that is brought in and given naloxone by EMS or by us, you know, typically they're not going to be, you know, you'd almost need to keep them 12 to 24 hours before they're in withdrawal, you know, enough withdrawal to really benefit from it. So sometimes these folks we are having to refer out, you know, if they're, you know, whenever they're awake enough to kind of leave the emergency department. It's more the people that are coming in, you know, when their last use was 12 to 24 hours ago and they're already in some form of withdrawal or they're seeking treatment specifically. We do get a lot of folks from the jail and prison system. And those ones are a little more difficult because it is hard to link them to care because depending on where they're, you know, where they're at from a legal standpoint, you know, they can't necessarily come to the clinic for follow-up. So sometimes those ones are just getting the Suboxone in the ED. And then, you know, we provide them with the information and, you know, if they're able to kind of get out, then they can come back to clinic.
Thank you, Dr. Lang.
Thank you.
I think there was a question about length of stay for these patients. I don't think it's terribly long. I don't have the data easily. I can grab it, but it's not one of our longer protocols. You know, I think there's rare ones where the tox group will see them and want to give them a second dose, and those ones stay. And I think the kind of pitfalls we've had with this, just from a programmatic standpoint, are sometimes you do get unmasked kind of poly substance withdrawal. We try to exclude folks that are in concomitant alcohol and definitely benzodiazepine withdrawal, but sometimes that stuff gets unmasked as they're withdrawing from their opiates as well, and those ones can be the more difficult to manage, and I think our admissions have been kind of from them. But
okay. Well, so that kind of wraps up our poster presentations. Thank you to all who have presented, Dr. Chandra, Dr. Lang, and Dr. Mayberry. I just wanted to take a few moments to thank Mady Van Otteren, Christy, and Belinda Chandler. Without them, like, none of this conference would have happened. Sorry, Christy Snicken and Belinda Chandler, and without them, like, we couldn't have gotten any of this stuff done. So thank you so much. If we were in person, I guess there would be a round of applause, but we can all put an emoji up. I'll put mine. And also would like to thank Vapotherm, who was sponsored for our program today. I invite my co-directors of Dr. Wheatley and Dr. Pena to add anything if I miss anything.
no, I want to thank everybody for coming. I wanted to put in a plug for those of us who are, or those of you who are ACEP members. Make sure you join the observation services section. Our section meeting, obviously ACEP is going to be all virtual. Our section meeting is on the Wednesday, I'll find out the date, from 1 to 3, the Wednesday of ACEP. I think that's the 28th. Yep, Wednesday the 28th from 1 to 3, and it'll be a Zoom meeting. There'll be stuff out about that. Obviously we've provided, and most of the speakers have provided their contact info. So, if you have questions, reach out to any of them specifically. More broadly, if you want to keep any of these other conversations going, because normally we would be talking in person, outside of whatever lecture hall or whatever we had this conference in. But, if you want to keep the conversations going, the ACEP OBS section Engage platform or the SAEM OBS interest group email platforms are good ways to reach out to the memberships of those organizations and ask questions and engage folks and get more of a robust conversation.
Yeah, I'll echo that, and also thank everyone for registering and signing up. And I really, I think we all hope that everyone has information and some good tips to bring back to their institution. And it's just great to have everybody here virtually, at least on one platform. And we will certainly do our best to try to move this conference out west whenever things allow us to do that. And I hope everybody stays safe and healthy throughout this pandemic that we're having. Thank you, everyone.
All right, thanks.
Thank you.
Thanks.
Thank you, everybody.
Thank you.